Okay, good morning. How is everyone doing? Can everyone hear my voice? How is everyone doing? Can everyone hear my voice? Okay, good. Welcome to the 23rd lecture of Dr. Heidi's Step 1. And for these lectures for this week, we are studying neurology. And we have finished quite a bit of the topics for the last 2 days. And hopefully we will be moving forward and we would hopefully try to finish neurology by this week. If not, we would need an extension of, let's say, a 1 or 2 days extra. But till now, we have covered a lot of high yield important topics, and you guys have been extremely helpful by putting your utmost attention. And thank you so much for doing that. And having said that, did you guys get some time to spend the rest of your days solving the UWorld questions? I keep on asking you guys every day the same question over and over again because I want to make sure that you guys are doing your UWorld questions. Okay, good. So basically, I wanted to talk a little bit about USMLE Step 1 in general before I started talking about the subject. Okay. So for everyone who are not well accustomed to what the USMLE is, okay. So USMLE is basically it's the United States Medical License Exam, which is a three-step process. Okay. For the first step, you have basic science and organ systems. For the second step, it's divided into clinical skills and clinical knowledge. And the third step is basically an accumulative exam, which can be taken during your residency or before your residency. And in order for you to land a proper interview in a well-renowned hospital, you have to get ECFMG certified. That is for the purpose of the students who are foreign medical graduates. So we have two boards over here. One of them is ECFMG. ECFMG is Educational Commission of Foreign Medical Graduates. Another one is NBME. NBME is your National Board of Medical Examinations of United States of America. That's what it is. So for the purpose of speaking on behalf of us, including myself, ECFMG certification is what we need. And in order for us to do that, we have to finish step 1 and step 2. So let's talk a little bit about step 1. Okay, I'm pretty sure you guys know that step 1 is basically an 8-hour long exam. It's divided into 7 blocks of 40 questions. Each block will get 1 hour. You will get 1 hour to finish each block. If you can finish it before that 1 hour, that extra time will get added to your break time. That extra time will get added to your break time. So you can take a break and that time will be added. Basically, if you have 7 blocks a day, after each and every block, you can take a break of 5 to 10 minutes. And that's how you divide your whole day of your exam. Um, before, so what happens is for USMLE Step 1, in order for this, on behalf of the students who are students of Bachelors of Medicine and Bachelors of Surgery, that is MBBS, okay? For the purpose of those students, we have learned quite a little bit. Even I have a bachelor's in medicine and a bachelor's in surgery. Okay, so I speak for the fact that we have learned quite a bit in our medical schools. Okay, but the thing about the step 1 exam is they try to go and dig a little bit deeper into our knowledge, and that's exactly what we are trying to smoothen and solidify with our lectures. And the way the thing goes is, in order for you to do absolutely well in USMLE Step 1 exam, you have to enter a period of dedicated study. Okay, you have to enter a period of dedicated study. And what do you mean by a dedicated study period? So let's say your exam is in, let's say your exam is in 6 weeks. Okay. Let's say you have your exams in 6 weeks. Can you guys hear my voice? Okay. Okay. So we are just talking about the step one exam in general before all the students come, because I just wanted to do a review of the whole exam. Okay. So let's say you have your exam in 6 weeks. Okay. Before the 6 weeks of your exam, you should have already entered your dedicated period. And by the dedicated period, what we expect is we expect the students to study every day for 6 days a week, around minimum of 8 hours to a maximum of 13 to 14 hours in a day. Okay. And you should be able to get a proper sleep for 8 hours a day. And let's say 2 more hours to prepare your food. And the rest of the day should be focused on doing, on learning about what you have learned before your dedicated period. Okay. So our goal with you guys, okay, our goal with you guys is our goal is to make you guys enter the dedicated period with absolute confidence. Okay. What we want to do is we want to make you guys masters of first aid. So we want to make you guys enter your dedicated period with absolute confidence. So when you enter your dedicated period, in that matter of 4 to 6 weeks, you are absolutely confident that you can revise and review first aid along with the UWorld. So that's our goal. Okay, and in order for us to do that, if it takes us around 3 to 3.5 months, or maximum, let's say 4 months to complete first aid, you can schedule your exam 4 to 8 weeks after our revision, hopefully. Okay, if you are absolutely confident. But in order for you to do that, not only do you have to read first aid, you would also have to solve the UWorld questions. Okay, so UWorld question solving is actually number one, because the resources which we expect our students to use are UFAP meaning UFAP, U for UWorld, FA for first aid, P for Patoma. Okay, so UWorld is number one. Then comes first aid, then comes your Pathoma lectures. Okay, and what we do is the first aid which you have to learn, we will help you learn it. We will help you learn it in the easiest way possible, what like we are doing already. Okay, so if we are doing that during our lectures, the rest of your day should be focused on doing absolutely nothing but UWorld questions and watching a bit of video the of the Patoma videos. Okay, there are a lot of other resources. You have BNB, you have Dr. Najib, you have you have a lot of other resources, but none of those are standard. None of those are standard resources. Okay, even our lectures are a resource for you. Okay, even our lectures are a resource for you, but our lectures are nothing different from learning first aid. So what our lectures are basically our lectures are helping you finish first aid from A to Z, from zero to from absolutely zero. Okay, so that's what we are trying to do. So we don't want to be another extra resource. We just want to be the guide for you to finish first aid as soon as possible. Okay, so that's what it is. So does anyone have any question regarding our lectures or regarding our guideline for your preparation? Does anyone have any question? Does anyone have any question regarding their preparations for USMLE Step 1? Okay, no questions at all regarding how much you should study, how long you should study, what to expect on the exam day. Okay, so how long? Okay. Yes, what is your question, Dr. Naud?
Hi, doctor. Can you hear me?
Yes, I can hear you. Let's see where you are. Okay. What is your question?
My question is, especially for me personally, what do you do if you have been away for the basic science for a while? So you start by revising the basic science first and going back to first aid and patoma, and then UWorld, or do you do like a quick scratch using videos of patoma or BMB, any other directory videos, and you go back to UWorld and first aid?
Okay, good question. Okay, so what I'm going to do is I'm just going to mute you for okay for a second. And okay, so thank you so much for asking that question. Okay, I really appreciate you guys sharing your obstacles so that I can put it out for you guys. Okay, so basically your question is, what if you have, so what if you are an old graduate, okay, and you have been out of touch for the basic science for a long period of time, and what can you do to smooth up the process? Okay, the thing which you can do and the thing which you can do is do the exact same thing which everyone else is doing. Okay, if you have been out of touch for a long period of time, if you have been out of touch from your basic science knowledge for a long period of time, you can still what you can do is when you go through our lectures, we try to break down the text and first aid into very little pieces that is exactly very easy for you to digest and swallow. Okay, so what you can do is, if you feel like you lack a little bit of confidence in your basic sciences, what you can do is after we are done with our basic science portion, every day before going to bed, you can do another small revision of your of an hour of your basic sciences. Okay, okay. But at the end of the day, if you master UWorld, first aid, and pathoma, okay, if you master UWorld, first aid, and pathoma all together, there's absolutely no reason for you to do any less than a new graduate. Okay, so first of all, what you should do is you should read the first aid with us. Then you can solidify that information by watching the loaded pathoma videos. Let's say you are doing neurology right now. After you are done doing our lectures, you can watch a video of pathoma. You can watch a video about neurology from pathoma. And once that knowledge is incorporated, okay, it's almost, let's say, around 60% in your mind. The rest of the 40% could be incorporated by doing questions. Okay, could be doing questions, because there are two types of learning. There is passive learning. Passive learning is what you are doing right now. Is you are just trying to absorb the knowledge, but you are not trying to apply the knowledge. Okay. Application of knowledge comes when you solve the questions. Okay. So once you absorb the knowledge passively, then you apply the knowledge. And once you apply the knowledge, once you start applying that knowledge gets stuck in your head for a long period of time. Okay, but what happens is you have to apply that knowledge then and then. That's why I keep on asking you guys every day, are you guys doing questions? Are you guys doing questions? Do you guys find questions in common to our lectures? That's because we want you guys to apply that knowledge right away, because what happens is first aid is so massive that after you guys are done reading neurology, there's a high possibility you guys will forget most of the information from cardiovascular system, if you have not applied that knowledge from cardiovascular system into your question form. Okay, so in order for you to solidify everything that we are talking about, even for all the students who are old graduates who has not been in touch with the basic sciences for a long period of time, it does not matter. As long as you apply the knowledge by doing questions, you will be just on the exact same track as everyone else, as absolutely everyone else. Okay, so that's that. I hope that answers your question, Dr. No. How many questions we should do per day? We should do around, let's say, if the UWorld has around 32 right now, it should have around 3,320 questions. So every day you should be doing at least one block, if you want to complete it in 3 months. Okay, so what we are going to do is okay, so what we are going to do right now is, it's 9:26. Okay, we will stop the discussion for our USMLE right now, and we will continue this after our lecture. If anyone has any more further questions, we will answer it after the lecture. But right now, I think it's about time everyone has joined the lecture. Let's talk about our previous lecture to see if you guys have understood everything that we talked about. Is everyone ready for a quick revision, recapitulation, and review? Okay. Okay. And one more thing, although we just provide you guys the lectures, please do not think that we are unavailable for any problems that you might be facing while you prepare for your exam. We want to be a guide. We want to be a mentor. Okay, so we appreciate a lot of the students reaching out to us with obstacles, asking us to provide them how they should exactly study. If you are also one of those students who need some help with guidelines about how a day in your life while you prepare the USMLE Step 1 should look like, please let us know and we would work with you. Okay. All right. Okay. So let's start with our revision. The first thing that I want to talk about are the stages of the sleep cycle. The stages of the sleep cycle. Do you guys remember the mnemonic that we used for the stages of the sleep cycle? What was the mnemonic once again, please? Let's see if who remembers. Okay, so bats drink blood. That's what we bats, not rats, bats. Okay, bats drink blood. Okay, bats drink blood. Okay, good. Okay, so what is the stage? What is the stage of the sleep cycle where night terrors occur? Night terrors, not nightmares. Night terrors. N3. Okay, next one. What is the stage of the sleep cycle where nightmares occur? Nightmares. Nightmares, REM sleep. Okay. What are the sleep changes in an elderly person? Sleep changes in an elderly person. Decrease REM sleep and okay. Okay. If you have decrease of REM sleep, what happens to the REM latency? Does it increase or decrease? That is correct. Increases. Okay. And the next one is what are the changes that we see in a patient with depression? Sleep changes that we see in a patient with depression. What are the sleep changes? So REM sleep time is high. And how about the REM latency? Low. Okay. Okay. Okay, good. Let's talk a little bit about the nucleuses of the hypothalamus. Okay, let's talk about the nucleuses of hypothalamus. Okay, so what is the lateral nucleus of the hypothalamus responsible for? Hunger. What is the ventromedial nucleus of the hypothalamus responsible for? Satiety. What is the anterior nucleus of the hypothalamus responsible for? Cooling. Okay, cooling and parasympathetic. That's good. What is the posterior nucleus of the hypothalamus responsible for? Heating and sympathetic. Okay, good. What is the suprachiasmatic nucleus responsible for? Circadian rhythm. What is the supraoptic and paraventricular nuclei responsible for? ADH and oxytocin. What is the preoptic nucleus responsible for? Preoptic, primitive nucleus, which is responsible for sexual behaviors and GnRH. Another important thing that is thermoregulation. Okay, thermoregulation. Good. Okay, now let's talk a little bit about our thalamic nuclei. Okay, please do not confuse hypothalamic nuclei with thalamic nuclei. Okay, so if you have a patient with thalamic stroke or ischemia or loss of blood supply to the thalamus, okay, what type of loss will you expect in that patient? Pure sensory loss or pure motor loss? Pure sensory or pure motor? Okay. Okay. Are you guys sure? Absolutely sure? Yes or no? Are you guys absolutely sure? Yes or no? Okay. Okay. So what if I tell you that that's your stroke or ischemia of the stroke or ischemia of the internal capsule? Okay, do you guys know about the internal capsule of the brain? Have you guys heard about the internal capsule? Okay. Okay, so if you guys have not heard about the internal capsule, we would be talking about this in a while. Okay, so what if I tell you that if there is a stroke of the internal capsule, that is responsible for pure sensory stroke? Am I correct or am I not correct? Am I correct or am I not correct? Okay, are you guys absolutely sure? Okay, okay, listen. So the reason why I am trying to confuse you guys, okay, so the reason why I am trying to confuse you guys, it's because you will receive questions in UWorld where the UWorld will try to confuse you. Okay, it does not matter if anyone tries to confuse you about anything. Okay, or you have to remember 100% that you can never mess this up. Okay, thalamic stroke is associated with pure sensory stroke, pure sensory. Internal capsule stroke is associated with pure motor. Is please write this down in your book right away. Okay, you will receive a lot of questions from this associations, and a lot of students will mess this up. Okay, a lot of students will mess this up. They will get confused in the last minute, and they will provide the wrong answer. Okay, right. So star, if you have to put stars, put like 3 4 stars. Write down thalamic stroke, pure sensory stroke, internal capsule stroke, pure motor stroke. Write it down and put stars. And whenever you go through them, read it at least once, please. Okay. Okay, good. Did you guys write them down? You guys want to write that down? Okay. 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 Once again, the sensation from the ventral lateral nucleus, is that sensory sensation, or it's or what type of a sensation does the ventral lateral nucleus of the thalamus collect? Okay. So try to realize that the ventral lateral nucleus is collecting information from the periphery, and it's delivering that information to the motor cortex. The ventral lateral nucleus of the thalamus it is collecting information from the periphery, and it is providing information to the motor cortex. So it is not a motor nucleus. It is not involved in your muscular contractions. Is it involved in your muscular contractions, or is it involved in the cerebellum? Right, position sense. So do you guys remember we talked about this yesterday, that the cerebellum and the cerebrum, they keep on talking to one another? Do you guys remember that? Do you guys remember that we talked about the fact how the cerebrum and the cerebellum, they keep on talking to one another? The cerebrum asks the cerebellum whether he should move the joint, and the cerebellum says back that if you have to move the joint, you have to decrease your impulses. And the way the cerebellum connects with the cerebrum, it is through the thalamus, right? Because the thalamus is the relay center, and the thalamus has the ventral lateral nucleus, which is allowing which is allowing the cerebellum to perform its task. So in a way, it's still a very sensory information. It is providing information to the motor cortex about the joint and position sense. Okay, so that the motor cortex can perform the function properly. So it is, although it does say that the senses are, it's a motor senses, okay, but it's providing the motor cortex with information about what the position of the joint is. Okay, so that's that. So please do not confuse about the fact that the thalamic nuclei has a motor nuclei. Okay, most of them, all of them are basically sensory nuclei. All of them are basically sensory nuclei. Okay. Okay, next one. Next one is, let's go very fast about the sensation. So we have ventral posterolateral nucleus of the thalamus. And what are the senses that are responsible for VPL? Fast answers, please. VPL senses: vibration, pain, pressure, and vibration, pain, pressure, and light touch. Okay, next one. What are the sensations for that goes through ventral posterior medial? Ventral posterior medial. What are the sensations that go through ventral posterior medial? Okay. What are the sensations that goes through lateral genicular body? Light. What are the sensations that goes through medial geniculate body? Medial for music. Okay, good. Okay, then we talk a little bit about the limbic system, and all I would want to know is what is the mnemonic that we used for the limbic system? Habit. That's the mnemonic we used, and if anyone could just write down the breakdown of habit. Hippocampus, amygdala, then mammillary body. Okay, good. Anterior thalamic nuclei. Then we are missing out on two more. Okay, entorhinal cortex and the cingulate gyrus. Okay, that's very good. Okay, then we talked about the pathways of the dopamine. So, which pathway is responsible for positive symptoms? Positive symptoms. Which pathway is responsible for positive symptoms? Mesolimbic. Which pathway is responsible for negative symptoms? Mesocortical. Which pathway is responsible for prolactinemia? Easy question. Tuberoinfundibular. Okay. And then the next one is nigrostriatal, which is responsible for extrapyramidal movement. Okay, so far so good, guys. You guys are doing really well. Okay, so thank you so much. And we're just very close to the end of the discussion. Before we do that, it's very important that we talk a little bit about the cerebellum. Okay, we will talk a little bit about the cerebellum. And the cerebellum, first of all, the cerebellum receives its information from the contralateral cerebral cortex and the ipsilateral side of the body. We just talked about that earlier. Okay, what I would want to know is what is the structure responsible for its communication with the cortex? Anyone else? Okay. Excuse me. Okay, so it's middle cerebral peduncle. Okay, so middle cerebral peduncle. So that's good. And okay. What is the structure that is used for communication with the spinal cord? It's inferior cerebral peduncle. What is the structure that is used for sending impulses to the brain? Sending impulses to the cortex. Sending impulses to the cortex is due to the presence of superior cerebellar peduncle. Okay, so that's good. Okay, that's very good. Okay, next one. Next one is your complicated basal ganglia, and we had quite a bit of a rough time understanding basal ganglia. Okay, but I do not want to get into the depths of discussing the pathways again, because to be extremely honest, this pathway is not going to be heavily tested in your exam, because the reason being is because there's not a lot of questions you can make from the pathways in that 90 seconds. Okay, in that 90 seconds which you will be provided, there's not a lot of questions which you can make from the pathways, but for your future learning we had to go in depth of the pathways because we do not want to leave any stones unturned. Okay, so that's why we went into the depth, but let's just learn about the pathways in a broader spectrum. First of all, what I would like to know is we have two pathways for the basal ganglia, direct and indirect. Which of the pathways are responsible for increase in motion? Direct. Which pathways involved for decrease in motion? And obviously the answer is indirect. Rhetorical question. Okay, good. Okay. And which receptor is being used for the direct pathway, and which receptor is being used? D1. That is good. Okay. Okay, that's good. Okay. Okay. So do you guys remember that we talked about Wilson's disease? Wilson's disease. Yes, you guys do remember. Do you guys remember that we gave it a name of our own? Who remembers that name? We gave Wilson's disease a name of our own. Very good, Dr. Jordan. And the name that we gave was, okay, very good. To all doctors who remember the name, we named the disease 13's disease. And we have a tendency of doing that for our own sake because it helps us remember about the diseases, okay? In the same way, we also named hemochromatosis as hemochromatosis. Okay, so we named the disease 13th disease. Okay, so what happens in Wilson's disease is in Wilson's disease, the copper deposition that happens, it happens in basal ganglia. Okay, and it also majorly happens in basal ganglia. It also majorly takes place in the hepatic structure, and that is why one of the names of Wilson's disease is hepatolenticular degeneration or lenticulohepatic of hepatic degeneration. Okay, so lenticular meaning lens. Okay, we talked about the fact that how the lentiform nuclei is important as it's one of the important structures of basal ganglia. So hepatolenticular degeneration. Okay, so if you ever receive any question about which parts of the brain are affected by copper deposition in Wilson's disease, okay, your answer is basal ganglia. Okay. Okay, good. So I think we're ready to move forward. Okay, it's 9:44. Perfect timing. Okay, and right now what we will be doing is we would be finishing cerebral perfusion, and then we are really excited about today's topics because we have a lot of diagrams, we have a lot of things that will be a bit fun to learn. Okay, so without further ado, let's begin. Okay, so what I will be doing is, give me 1 second, and okay. Okay, can you guys hear my voice? Okay, so can you guys hear my voice? Okay, good. So you guys can hear my voice. That is great. Okay, so let's start with today's lecture. So from today, what we are going to do is we are going to start with cerebral perfusion. Okay, cerebral perfusion, and basically, what is cerebral perfusion? The word perfusion meaning that blood supply, persistence of intact blood supply to the cerebral hemispheres. Okay, and it relies on absolutely tight auto-regulation. Auto-regulation meaning that the regulation of the blood flow, meaning increase or decrease of the blood flow, is dependent automatically. Okay, there's no way you can control it. Okay. Um, and the best part about this blood supply to the brain is most of the parts of our body are dependent on oxygen. Depending on how much oxygen there is, the blood supply is tweaked or treated accordingly. But for the purpose of your brains, okay, it's driven, the blood supply is driven by the partial pressure of carbon dioxide. Okay, the partial pressure of carbon dioxide, primarily, this is what's important. This is what's important. So if you have let's say that in a patient, okay, that let's say that in a patient who has increased in intracranial pressure, okay, increase in intracranial pressure, increase ICP, or let's say in a patient who has increased intracranial pressure, or let's say in a patient who has cerebral edema. Okay, we know what happens in cerebral edema. That is like any other edema. There is dilatation of the blood vessels, and then there is leakage of fluid into the interstitial space, right? So right now, if you have to have your partial pressure of carbon dioxide, okay, if the partial pressure of carbon dioxide in the brain, if it's increased, what happens is there is increased amount of blood flow, and for increased amount of blood flow to take place, the blood vessels have to dilate. So in a patient with cerebral edema, if there is increased amount of partial pressure of carbon dioxide, and there is increased amount of blood vessel dilatations. What this will do is this will make the cerebral edema worse. Okay, and this will exacerbate the cerebral edema. So what happens is in patients who have cerebral edema, there is a condition that we can perform. This is known as therapeutic hyperventilation. So therapeutic hyperventilation, what happens is when you hyperventilate, okay, what happens is when you hyperventilate, you get rid of the excess carbon dioxide, and your partial pressure of carbon dioxide falls. And as soon as your partial pressure of carbon dioxide falls, what happens is instead of vasodilatation, your blood vessels undergo vasoconstriction. And what happens when that happens, that what it does is this temporarily, not permanently, this temporarily solves your problem, or at least try to fix or stop the edema. Okay. At the same time, what this will do is this will also help a patient with increase of intracranial pressure. How? Because if a patient has a low blood supply to the brain in increased intracranial pressure, this will help tone down the signs and symptoms. Okay, and the reason and the way that you will see a lot of this taking place is in intensive care units. Okay, so in intensive care units, you have patients with cerebral edema who are comatose, or who have decreased who have decreased um, what's the word I'm looking for, who has decreased okay, at times I have like word farts. Okay, so what happens is, let's say in a patient in an intensive care unit who have decreased responsiveness. Thank you so much. Okay, so that's the word I'm looking for. Okay, so in a patient in intensive care unit who have, let's say, decreased responsiveness. Okay, what happens is if the patients are on mechanical ventilators. Okay, we know that the mechanical ventilators, they can you can change the rate of respiration through the mechanical ventilators. And what happens is if you make the patient hyperventilate through the machine, this will help solve the problem for a patient with cerebral edema and who has decreased responsiveness, because those patients cannot hyperventilate by themselves because they have decreased, either they're comatose or they're absolutely too tired from the disease to do it for themselves. So the thing is, in NBME, okay, in your NBME, not in UWorld, you will receive a lot of questions from this one. Okay, so in your NBME, you will receive a lot of questions about therapeutic hyperventilation. Okay, so I will give it 2 stars. So just try to understand the concept. Okay, the concept is basically very simple. The simple concept is the blood supply of the brain depends on partial pressure of carbon dioxide in a patient who has cerebral edema or increased intracranial pressure. If you make the patient hyperventilate, either by themselves or mostly, in most cases, by mechanical ventilators, you can primarily or temporarily solve the problem. Okay, that's what it is. Okay, the next thing that we're going to talk about is it also relies on the pressure gradient, meaning that the perfusion, it also relies on the pressure gradient between the mean arterial pressure. So as you can see that the mean arterial pressure over here, okay, and it also depends on the intracranial pressure. So depending on the mean arterial pressure and the intracranial pressure, okay, the cerebral perfusion will increase or it will decrease. And this is basically very easy to understand because the mean arterial pressure is basically, do you guys remember how we talked about the fact that the mean arterial pressure, does it represent preload or afterload? Let's see who remembers what the mean arterial pressure represents. Preload or afterload, mean arterial pressure? Okay, afterload. Okay. So basically, if in a patient you have increased amount of cardiovascular afterload, will there be increased blood supply to the brain or decreased blood supply to the brain? Increased, if there's increased afterload, decreased blood supply to the brain. So if the mean arterial pressure increases, the blood supply will decrease. Okay, another thing is, if in a patient, let's say that this is a blood vessel of the brain, okay, and the surrounding intracranial pressure is absolutely too high. Let's say like over here, the pressure is so high in the intracranium, it's pushing on the blood vessels over here. It's pushing on the blood vessels over here, okay? And if there is pushing on the blood vessels, will there be increased blood supply Will there be increased blood supply through this vessel or decreased blood supply? And that's a very common rhetorical question. And is the answer, please? The answer is decreased blood supply, obviously. If you have increased intracranial pressure, your blood supply will obviously decrease. So that's what it is. Okay, so that's how they are dependent. Okay, that's how they are dependent on the mean arterial pressure and increased intracranial pressure. Okay, and there's another thing which we can do is that if the cerebral perfusion pressure could be calculated by calculating the mean arterial pressure minus the increased intracranial pressure. If it is zero, then there is no cerebral perfusion. So this is one way how you can calculate brain death in a patient if you want to declare that the patient has passed away. And in order for you to do that, you have to successfully calculate whether there's blood supply to the brain or not. Okay, because as long as the brain is alive in certain states of the United States of America, the patient is allowed to be stayed on mechanical ventilation for a long period of time. Okay, so in order to take the patient off of the mechanical ventilator, the patient has to have cerebral death or brain death. And the way that you can do that is by calculating the cerebral perfusion pressure. And the easiest way that you can do that is by subtracting the ICP from the MAP. That's what it is. Okay, you won't receive a lot of questions from this one, but this is just for your practical information and knowledge. Okay, and always remember that the perfusion pressure is directly proportional to the partial pressure of carbon dioxide. Okay, until the partial pressure of carbon dioxide is more than 90 over here. Okay, so what happens is, as you can see over here, that the cerebral blood flow keeps on increasing, but at 90, what happens is it levels down. Okay, it levels down and it forms a straight line. That's what it is. Okay, so what type of questions will you receive from this paragraph over here? What type of questions will you receive from this paragraph over here? It's this one question, that is therapeutic hyperventilation. That is number one. Okay, you won't receive a lot of questions from this graph. And another one that you can receive is a direct question, that what happens in a patient with increase in partial pressure of carbon dioxide, and in a patient with increased partial pressure of carbon dioxide, the blood supply to the brain is increased. That's what it is. The blood supply to the brain is increased. Okay, so is everyone clear about cerebral perfusion pressure? Any questions? Is everyone clear about cerebral perfusion pressure? Do we have any questions? Okay. Okay. So what's happening over here is, okay, what is your question again, Dr. Hassan? I can't break it down. If, okay, if mean arterial pressure increases, does the cerebral perfusion pressure increase or decrease? Okay. What's happening with mean arterial pressure? Okay. What's happening with mean arterial pressure? First of all, what is the mean arterial pressure? The mean arterial pressure is the pressure that is the afterload, right? The mean arterial pressure is the afterload. And the afterload is basically the force that is against which the heart has to pump blood, right? The afterload is basically the pressure or the force in the circulation against which the heart has to pump blood. Okay, so that's what it is. And in order for the heart to pump blood, if the pressure outside of the heart is less, the heart can pump the blood easily. And if that's what happens, if that's what happens, then the blood supply to the brain will increase. So to answer your question, if mean arterial pressure increases, the blood supply to the brain will decrease. Okay, does that answer your question? Okay, good. Okay, okay, let's move on. Okay, let's move on. So any more questions from the cerebral perfusion pressure before we move on? We don't want to hurry. We want to make sure everyone has understood. Okay, so in the diagram, it shows the increase. Okay, so what happens is, let's say that over here, look, what's happening with the mean arterial pressure is that the mean arterial pressure, uh, look, at this. If the mean arterial pressure increases up to a certain point, the cerebral blood flow is, it does not mean that it's increasing as much. This shows that there is no change in the mean arterial pressure. I mean, in the cerebral blood flow. Okay. So when the arterial pressure increases, there is absolutely no change. But after a certain period of time, what happens is, if there is increase in mean arterial pressure, there is very minimum increase of the blood flow to the brain. There's very minimum increase, but overall the blood flow to the brain, it decreases. Overall, the blood flow to the brain, it decreases. Okay. Any more questions? Okay. Okay, so let's move on to our next to our next one. That is the homunculus. Okay, let's move on to this one. And before we move on to this, I just really want to make sure that you guys have perfectly understood the cerebral perfusion pressure or not. And what I want to tell you guys is that you guys will receive absolutely no more than two questions from over there. And those two questions are, first of all, what is therapeutic hyperventilation, and what happens to the blood supply of the brain when the partial pressure of the carbon dioxide is increased. Okay, so have you guys understood this? Because I will not move forward until the knowledge you guys have. Why does high intracranial pressure decrease cerebral perfusion pressure? If there's high intracranial pressure, we use this diagram, then this will put pressure on the blood vessels and this will stop the blood supply. Okay, what is your question, please? What is your question? Okay, good. So does that help answer your questions too? Okay, good. Okay, let's move forward. Okay, let's move on to the homunculus. Okay, and before we address this diagram, let's talk a little bit about, let's break this diagram first by ourselves. Okay, so what the homunculus is, okay, the homunculus is basically the parts of the brain that is involved with sending impulses to different parts of the body. So we have two homunculus. We have a motor homunculus and then we have a sensory homunculus. Okay, the motor homunculus is responsible for sending impulses to the muscles, and the sensory homunculus is responsible for receiving information from the peripheral parts of the body. So let's draw two cerebral hemispheres at first. Okay, so this is a very rough diagram of one cerebral hemisphere. Okay, and this is another one that we will draw for the sensory part of the brain. Okay, the sensory part of the brain. Okay, that's what we would do. Okay, so always remember that the homunculus, okay, that the homunculus, what's happening over here. Okay, let's talk about the motor one first. Okay, let's talk about the motor homunculus first, then we will move on to the sensory. Okay. Okay. Well, so let's say that this is one cerebral hemisphere. Okay, and what's happening over here? It's that uh, you have the parts of the brains. Okay, so you have okay the okay, so you have the parts of the brains, and these are the parts. Okay, okay, okay. So what is this lobe? Does anyone know the name of this lobe? Because this is just a lateral view of the cerebral hemisphere. What is the name of this lobe? Okay. Anyone else? What is the name of that lobe that we just draw? Okay, what is the name of this lobe over here? And what is the name of the lobe beneath this? Okay. Okay, so basically what this is this is not just the frontal lobe. Okay, this is the frontal lobe and just a part of and just a little bit of the parietal lobe. Okay, so this is just a mixture. Okay, so this part is it's the mixture of the lobes. This is the part that is supplied by anterior cerebral artery. Okay, okay, this is basically mostly your parietotemporal lobe. Okay, altogether. So that's why I asked you, because these are mixtures of these are mixtures of lobes. Okay, so that's what it is. And so this is the part that is supplied by anterior cerebral artery. This is the part that is supplied by middle cerebral artery. Okay, and these are the part that is supplied by posterior cerebral artery. These are the part that is supplied by posterior cerebral artery. Okay, okay. So now that we have figured out what the lobes are, okay, let's draw our homunculus. Okay, okay, so let's draw our homunculus. So the homunculus is basically, once again, the parts of the brain that is involved with sending impulses. And for this one, this is a motor homunculus. That's what we're going to do. Okay, so for the motor homunculus, first of all, we always remember that it starts with a leg. Okay, so it starts with the legs over here. It's as if, okay, so it starts with the legs. Okay, and then you have the arms. Okay, and then you have a hand. Okay, and the hand is a really big hand, and the reason why is I'm going to tell you. Okay, so if you had to draw the arms and the legs, okay, so this is basically the arm. Once again, I apologize for my diagram, for my drawing skills, they're horrible. Okay, okay, so this is the leg, and as you can see that the leg is of a regular size, and the arm is a bit bigger. Okay, I'm going to tell you the reason in exactly 1 second. The next one is your face. Okay. Okay. So this is basically your face. Okay. Okay. And your tongue. Okay. So that's what it is. So what's happening over here is that this part of the brain, okay, this part of the brain of the cerebral cortex, of the motor part, okay, this is involved for your sending your impulses to the leg. Okay, and then this keeps on going all the way from the toes, ankle, then you have knee, hip. Okay, then you have your shoulders, elbow, wrist, and then you see how big the hand is. The hand is big because this part of the hand is this part of the brain is highly dependent on doing functions of the hands, because the reason being is because when you work your fingers, working your fingers are absolute fine movements, are very fine movements. So multiple sections of the brains have to work at the same time to make proper adjusted movement that is always perfect 100% of the time throughout the day or throughout the year. Okay, so this part of the brain is highly developed, and this part of the brain is highly important for sending proper impulses, for the proper functioning of the fine movement of the fingers. Okay, and then these parts are the ones that are involved for sending impulses to the brain. Okay, please keep in mind that the occipital lobes over here, they are not responsible for sending impulses. It ends all the way over here. Okay, so that's that. So this is basically your motor homunculus. Okay, this is basically your motor homunculus. And then you have your sensory homunculus. Okay, the sensory homunculus, I'm just going to draw over here. Okay, so this is basically what the motor homunculus is, and this is your sensory homunculus. Sensory homunculus is what's happening is you have more or less the same thing. Okay, you have more or less the same thing. So this is the part of the brain that is responsible for your face. Okay, okay, this is the part of the responsible for your face. Okay, that's your tongue, by the way. It's not a cigarette. Okay, so I'm just going to, okay, that's your tongue. Okay, and over here, okay, these are your arms once again, and then all the way this goes back, and that's your leg. Very simple. It's absolutely very simple. If you can try to understand what the motor homunculus is, first of all, draw the D and then draw a face. And then after you draw a face, draw an arm and a leg. Just only remember that for the motor one, the hands are big. And the hands are big, which represents that this part of the brain is highly developed for making fine movements of the fingers. Does anyone have any question regarding the understanding of the motor and the sensory homunculus? The motor homunculus and the sensory homunculus? Okay. How will you guys receive questions from the motor homunculus and from the sensory homunculus? Okay, so basically the way you guys will receive questions is you guys will, let's say, get a diagram an NBME like this one, okay? And then these parts will be labeled, okay? Okay. And now if I ask you, let's say from this diagram, this is a diagram of the motor homunculus, which of this labeling A, B, C, or D is responsible for movements of the elbows? A, B, C, or D? Which one is responsible for movement of the elbows? What is your answer? B. That is correct. Okay, which one of these is responsible for movement of your tongue? Of the tongue. D is the occipital lobe. Which one of this is responsible for movement of the tongue? Okay, C. Okay, so for the doctor who does not understand what the homunculus is, the homunculus is basically divisions of the brain that is responsible for sending impulses to specific parts of the body. If you want to move your leg, this part of your brain will get activated. If you want to move your hands, this part of the brain will get activated. If you want to move your tongue, this part of the brain will get activated. If you want to feel sensations from your leg, this part of the brain will get activated. If you want to feel sensations from your hands, this part of the brain will get activated. And if you want to feel sensations from your face, this part of the brain will get activated. Okay, now do you understand what the homunculus is? There are two heads on the sensory. How? There are two heads. Where do you see the two heads? Where do you see the two heads? In first aid in the picture. Okay, let's see what the first aid picture is. Okay. Okay, let's see the first aid picture. Okay, where do you see the two heads? This is the head for the sensory. This is the head for the motor. Okay, so neck. Okay, so what is the question once again? What was the question again, please? Because I'm having a difficult time understanding what you are asking for. What is for the neck? Okay, the neck is over here, and right, that's what it is. So what is the question? She means the head near the word sensory. Okay, the head near the word sensory. Oh, this one. Okay, neck and head. Okay. Oh, okay. So that's what's confusing you. Okay, so okay, do not focus on this. Okay. Oh, this head. Okay, this head and this head. Okay, okay. That's okay. Now I understand. Okay, listen. Okay, second portion is sensory. Okay, this head and this head. Okay, so first of all, what's happening over here is, let's say that this is your hand, right? And then you. Okay, so let me break it down for you because this is exactly the same thing. Okay, so what's going on over here is you have the hand over here. Okay, and if there are impulses that have to go, this is the part for where you have your shoulders. Okay, this is the part where you have your shoulders, and when you want to move your shoulders, so this is the one we're talking about, the sensory portion. Okay, try to understand that for the motor one there's absolutely no extra head over here, but for the sensory one, what happens is, since you have the sensations from the shoulder, they would like you to know that the shoulder and the neck receive the same sensations from this part of the homunculus, from this part over here. Okay, so that's why they drew two head. That does not mean that the face is being supplied for, or the face is or this part of the brain is responsible for facial sensations. Okay, always remember, face is already for over here. Okay, the head that they drew over here is just for your shoulder and neck. That's it. Does that answer your question? Okay, are you clear? Who asked the question? Let's see what the question. There are two heads. Okay, so Dr. Uday, are you clear? Okay, so what are they representing? They are just representing the fact that since the shoulder is there, the neck is also being supplied by that portion of the brain. That's it, nothing more, not the face. Okay, please do not confuse the face, because the face is supplied by the region that is lower than this region that's over here. Okay, should we move on? Do you guys have any questions? Clear? Okay, good. Thank you so much. Thank you so much. So this is basically how your questions will be asked in UWorld. Okay. Okay, so that's basically your motor homunculus. Okay, now let's read the diagram and let's see if we have drawn the exact same thing. Okay, so basically the homunculus is a representation of the areas in the cerebral cortex, and they have a distorted appearance due to certain body regions being richly innervated, as per example, as what we talked about. So meaning this part of the hand is richly innervated by this part of the brain. Okay, that's what it is. Okay, and then we also talked about the blood supplies, anterior cerebral, middle cerebral, and the posterior cerebral. Okay, that's what it is. Okay, so any more confusions about the homunculus? I want to keep on asking you guys questions about each and every section before I move on, because I want to make sure you guys have absolutely no questions before we move on. Okay. Okay, you have a question. Okay, does the left and right supply to the sensory or motor area? Like, does the right side provide sensory? Okay, okay, good. So, okay, good. So what your question is, you are asking whether if this is left and this is right, and whether the right is responsible for sensory and the left is responsible for motor. Okay, and my answer is absolutely no. Okay, this is basically the same regions of the brain. Okay, these are basically the same regions of the brain receiving both of these impulses at the same time. So this could be right, this could be right. Okay, so that's what it is. So it's not like this is the right brain, this is the left brain. Okay, this is the part of the brain from where they're receiving both motor and sensory. Okay, does that answer your question, Dr. Damilola? Okay, good. Next question. Is the head more innervated in the sensory part? Is the head more innervated in the sensory part? No, it's not. Okay, it's just the same innervation as it is with the motor one. Okay, so no extra innervations. Okay, any more questions from the homunculus? No more questions. Okay, hopefully that's what it is. Okay, next thing what we are going to do is we're going to do another diagram, and that's why I'm loving today's lectures, because we are finishing the whole text by doing diagrams on our own. Okay, the next thing that we would be doing is we would be learning about the broad spectrum blood supply. Okay, we will be learning about the broad spectrum blood supply of the brain. Okay, so broad spectrum blood supply, I'm pretty sure you guys know exactly what's going on over here. So let's say if this is your brain, okay, and this is how your brain would look. Okay, this is how your brain would look from the anterior side, or if you try to view your brain from the lateral side. So what's happening is, let's say if a person is like this. Okay, if this is your patient, okay, this is the part of the brain. So if you view the brain of the patient like this, then this is how the brain would look like. Okay, okay, so that's what it is. Okay, so from this diagram, what we have to do is we have to understand which of the regions of the brain are highly innervated by which arteries. Okay, we have three major arteries, which are ACA, meaning anterior cerebral, middle cerebral, and posterior cerebral artery. And for if you view the brain like this, okay, the arteries that is responsible for most of this portion over here, okay, most of this portion over here, okay, this artery is middle cerebral. This artery is middle cerebral artery, and up to here, this is anterior cerebral, and up to here, this is posterior cerebral. Okay. Okay, do not worry. We will tell you everything about the circle of Willis, and then we will tell you exactly where these arteries are coming from, where do they end. We will break down every single detail. But for now, did you guys understand the division of the arteries of the brain of the lateral side? Let's see, yes or no? Okay, good. Next one. Next one is if you view the brain, if you view the brain from this side. Okay, let's see if you view the brain from this side over here. Okay, so if you view the brain like this, so if you view the brain like this, then that's exactly what you would be seeing. Okay, if you view the brain through this side, what would you be seeing? You would be seeing, let's say you draw the brain again. Okay, if you view the brain like this, what would happen is And let's say this is your corpus callosum. Okay, and then these are the structures over here. Okay, and then if you do a division, okay, that's what it is. Okay, so this is the part which is supplied by posterior cerebral. Okay, this is the part that is supplied by posterior cerebral. This is the part that is supplied by anterior cerebral, and this is the part that is supplied by middle cerebral. Let me just use that one. Okay, middle cerebral. Okay, so the main question in concern, is majority of the blood supply of the brain. When you look at it, when you look at the brain from this side, that is from the lateral view, the majority is middle cerebral artery. If you look at the brain from that side, the majority is posterior cerebral artery. Okay, well, posterior cerebral and anterior cerebral, but but the middle cerebral is the least amount of blood supply when you look at the brain from that side. Okay, another one is if you look at the brain from beneath, okay, from underneath. Okay, so let's say this is how your brain looks from underneath. Okay, then majority of your blood supply over here is basically, okay, the majority of the blood supply over here is posterior cerebral. Okay, and then you have a little area, over here. Okay, this little area, this is anterior cerebral, and the rest are supplied by middle cerebral. Okay, okay, so what is the whole point of discussing all of these things? The whole point of discussing all of these things is, second diagram represents the inner brain. After cutting it, you write, if you see the brain from the medial view, from the medial side like this, from over there, if that's how you view, then that's how this part of the brain would look like. Okay, so whole point of discussing all of this is, so let's say you do a postmortem. Okay, let's say you are the coroner doctor who is doing a postmortem on a patient, and in that postmortem of the patient, you see that the brain is like this over here, and you're seeing the brain from the lateral side. If you see an area of infarction over here, okay, if you see an area of infarction over here, that this part has gone all black and that it's necrosed, right? Which artery would you suspect that has the decreased blood supply? Yes, and your answer is A. Okay. This time, if you have the necrosis on this side, okay, which would you suspect? Posterior. And the same way over here, if you see that your answer should be ACA. Okay, next one is if you see it from the beneath and if there is an infarction over here, oh, your answer is PCA. If it's over here, it's ACA. If it's over here, it's MCA. So this is just for your broad spectrum knowledge that which part of the brain is majorly supplied by which artery. Okay. And for the purpose of your step one exams in your USMLE, what you can get questions from these are, you can get scans, you can get direct scans. Okay, and I'm pretty sure you guys will receive questions from this discussion in your NBME. Okay, in your NBME, if you saw the NBME, what they will tell you is that they will have they will have pictures of the brain, and then they will have labelings, and then they will ask you directly which artery is occluded for this necrosis to take place, and your answer should be directly anterior for this, posterior for this, or middle for this, depending on what the question is. Have you guys understood what I'm talking about? Okay. Okay, good. Okay, let's go back to our text. Okay, so that's what it is. We just discussed this. Next one is we want to go talk about the watershed zones. Okay, we want to talk about the watershed zones. Okay, the watershed zones are basically, what do you mean by the watershed zones? Watersheds mean that the area in which there is anastomosis between two types of arteries. Okay, and the watershed zones are extremely important zones, and they not only are they present in the brain, they're also present in the GI tract and other parts of the body. And watershed zones are important because they help us identify where the first possible area of ischemia could be. If there is decreased blood supply for any reason, okay, if there is decreased blood supply or ischemia, okay, these are the parts of the brain which are the watershed areas which can undergo ischemia at first. Okay, why? Because these are the parts where anastomosis is taking place. Okay, so having understood what watershed means, let's read the text. These are basically the cortical zones which occur between the anterior and middle cerebral and posterior cerebral arteries. Okay, so meaning that these areas of anastomosis between the anterior cerebral and the middle cerebral, these areas are the watershed areas, the borders. Okay, so the internal borders occur between the superficial and deep vascular territories of the middle cerebral artery. Okay, so what's happening is over here they're showing the anastomosis between anterior cerebral and middle cerebral. So these are the watershed areas, and over here they're showing the anastomosis between the middle cerebral and the posterior cerebral, and this is your areas of anastomosis. Okay, and if you have a patient with hypoperfusion, okay, or low blood supply, okay, in the proximal part of the body, okay, can you guys name one congenital cardiovascular condition in which there could be increased blood supply in the upper portions of the body and decreased blood supply in the lower portions of the body? What is the name of the condition? Okay, very good. Okay, coarctation. Coarctations of aorta. Okay, so coarctations of aorta. Okay. Okay, so what happens is, let's say if you have a patient with coarctation of aorta, okay, if you have a patient with coarctations of aorta, will there be increased blood supply to the brain or decreased blood supply to the brain? Increased blood supply to the brain. Okay. So if there's increased blood supply to the brain in a patient with coarctation of aorta, okay, so this can result in, let's say if you have increased blood pressure, okay, this put the patient at increased risk for aneurysms and aneurysms? Yes or no? Yes. So if the patient has aneurysm, then will there be decreased blood supply or increased blood supply? After there is aneurysm, after aneurysm, decreased blood supply. If there is decreased blood supply, which areas of the brain will get affected first? Which areas of the brain will get affected first? The answer is watershed areas. Okay. So next time, if anyone asks you, can you get infarctions in the watershed zones after you have, if you have a patient with coarctation of aorta, your answer should be yes. After there is aneurysm and after there is, okay, after there is aneurysm, there is decreased blood supply. And after decreased blood supply, there could be your infarction of the watershed areas. Okay, that's what it is. Okay, okay. And what happens is, if you have a patient also with severe hypoperfusion, there's proximal upper and lower extremity weakness. Okay, and what happens is there's also a high order dysfunction, meaning that the visual dysfunction. So we have just talked about the homunculus, right? So if there are, let's say, areas of this part which are affected, areas of this part which are affected, then what would happen is these patients will have decreased motor innervations and they will get weaker. Okay, and at the same time, they will also have decreased sensations because these parts of the brains are not working. And if you have infarctions of these parts of the brain, then this will disturb the visual pathway. So the patients will have difficulty in seeing. So that's what it is. That's exactly what they're talking about. Okay. Are you guys confident about what we have just learned? What do you mean by aneurysm? What is an aneurysm? Dilatation. Okay. What happens is, if you have a patient with long-standing hypertension, this results in weakening of the walls of the blood vessels, and with existing hypertension, this puts pressure on the walls, and there is balloon-like dilatations of the arterial walls, and there could also be bursts of the arteries, right? And that could result in decrease of blood supply to the distal segments. At the same time, if you have a patient with aneurysm without any burst of the aneurysm, this could also result in seeping of the fluid from the arteries into the interstitial space. High yield. Okay, so high yield question from here. High yield question from here. I have just discussed about the fact about the high yield questions, that understanding the watershed zones are the ones. Okay, so understanding this diagram is your high yield. That's it. Nothing else. There's not a lot of high yield questions you will receive from these discussions we are doing right now, but because this is just for your basic knowledge, so that when you read the future texts, it's easy for you. Okay. Understand? Okay, good. Okay, now we will be talking about the circle of Willis. Okay, the circle of Willis, one of the most important things to learn. Okay, so that's what we're going to do. Give me 1 second. Okay, let me take another page. Okay, the circle of Willis is basically the circle of Willis is basically the circle. Okay, let's talk about the circle first. Okay, look. So this is the circle of Willis. So if you see the brain from underneath or from the inferior surface, then you can see the circle of Willis. And then patients, it I'm not sure if you guys have handled cadaver brains or brains of cadavers. Then you guys, if there was if you guys have seen an intact brain, then you guys should have witnessed the circle of Willis on the inferior surface of the cadaveric brain. Have you guys seen a cadaveric brain? Have you guys handled cadaveric brains? Okay. Okay, so that's what it is. Okay, good. So if you guys have handled cadaveric brain or do see cadaveric brains in the future, please try to notice the presence of this circle of Willis in the inferior surface of the brain. Okay. Okay, so this is what the circle of Willis is, and we are going to break this down into a very, very easy knowledge for you to digest and swallow. Okay. Okay, so what's going on over here is it's first of all, what's going on is you have, okay, okay, let me just increase the thickness. Okay, okay, all right. So first of all, what you have is you have this one artery. Okay, okay, you know what? I think I'm just gonna go from the heart. Okay, so let's say this is your heart. Okay, okay, this is your heart. This is the arch of the aorta. Okay, this is your heart. This is the arch of the aorta, and this is the right side. Okay, this is the left side. Okay, okay, and I'm pretty sure you guys know that this is the brachiocephalic trunk, which gets divided further into right common carotid, right subclavian, and then this is your left common carotid and left subclavian. Okay, so we have two subclavian arteries, left subclavian and right subclavian. So from the left and right subclavian arteries, okay, of the aortic arch, okay, the left and right subclavian arteries, you get rise of this two blood vessels. So from the right subclavian artery, you get right vertebral artery, and from the left subclavian artery, this is from the left sub. So this is from the left side. So from the left subclavian artery, you get the left vertebral artery, and from the right side, you get the right vertebral artery. Okay. So what happens is these two vertebral arteries, they arise from the subclavian arteries, and what they do is they join each other. Okay, they join each other and they form this one artery, and this is known as the basilar artery. Okay, so we're just going to um, name them really quick. This is your vertebral, okay, and this is your basilar artery. And what happens is that the basilar artery, what this does is this goes all the way up. Okay, this goes all the way up, and over here the basilar arteries ends. So the basilar artery ends into two more arteries, or it branches off into two more arteries, and these arteries over here, okay, this is known as posterior cerebral. Okay, so posterior cerebral, so PCA. Okay, posterior cerebral artery, posterior cerebral artery. Okay, that's what it is. Okay, so posterior cerebral arteries. Have you guys understood till now? If you guys have to track the artery supply from the heart, okay, okay, good. So nothing complicated has happened as of yet. Okay, hopefully it will stay like this. Okay, so what's happening right now is from the from this portion of the vertebral arteries, okay, you have another artery which forms, okay, like a tail. This artery branches off from the vertebral artery. This artery is known as anterior spinal artery. Okay, this artery is known as anterior spinal artery. Okay, this is known as anterior spinal artery, and okay, anterior spinal artery. And over here, this is the first portion of the circle of Willis which we want to focus on. Okay, this is the first portion of the circle of Willis which we want to focus on. The circle is basically made from two major branches. So first branch was your vertebral artery, and the another branch will be internal carotids, and we will be going to that in 1 second. So let's just complete this branch first. So first of all, we have the vertebral arteries from the subclavian. Okay, both of them on two sides, they join together to form the basilar artery, and then they bifurcate into the posterior in right and left posterior cerebral artery. Okay, and now from over here we have some more branches. Okay, so we have some more branches. What we have is we have the cerebellar blood supply. So blood supply to the cerebellum. So the blood supply to the cerebellum is basically you have, okay, you have superior blood supply and then you have inferior blood supply. So superior and inferior, and even from the inferior you have an anterior and a posterior. So first of all, let's draw the superior blood supply. The superior blood supply will stay here. Okay, then we have an inferior blood supply, and this is the anterior part or the anterior inferior. Okay, and this, then again we have this one, which is another inferior or posterior inferior. Okay, so that's all that has happened till now. So this is your superior cerebellar artery. Okay, this is your anterior inferior cerebellar, not cerebral, cerebellar. Okay, cerebellar artery, and this is your posterior inferior cerebellar artery. Okay, now what's happening is if anyone asks you, where does the superior cerebellar artery come from? Where does the superior cerebellar artery come from? What is your answer? Vertebral artery or basilar artery? Artery. If anyone asks you, where does anterior inferior cerebellar artery come from? Anterior inferior cerebellar artery. Vert Same, basilar. That is good. Okay. Okay, so it's okay over here. If anyone asks you where does the posterior inferior cerebellar artery come from, what is your answer? Vertebra. Okay, so that's what it is. And then we have another small branches over here. Okay, we have these small branches. Okay, very small branches. Okay, these are known as lateral pontine arteries or pontine arteries. Okay, so pontine arteries are basically blood supply to the pons. Okay, so blood supply to the pons or pontine artery. Okay, pontine. So this is one diagram which is done. Are you guys confident that you guys can draw this by your on your own? Are you guys confident you can draw this on your own? This is very clear, very easy. Okay. Okay, good. So we have drawn the first segment. Okay, let's draw the second segment. Okay, let's draw the second segment over here. Okay, for the second segment, let me use this one. Okay, okay. So for the second segment, what's going on is you have the internal carotid artery. Okay, so first of all, let's just draw the internal carotid artery. Okay, so once again, if this is the heart, okay, this is the heart, arch of aorta, right side, brachiocephalic. Okay, left side you have left subclavian, left common carotid. Okay, and then the brachiocephalic gets divided into right common carotid and right subclavian. Right, so right subclavian, right common carotid. And so we already talked about the fact how both of the subclavians are responsible for both of the vertebrals. Now we have to talk about the common carotid. Okay, so the right common carotid and the left common carotid and the right common carotid. So the right and left common carotid, okay, the carotid arteries, they divide into two branches. One is your external carotid artery, another one is your internal carotid artery. So what happens is that the external carotid artery, artery, they go and they supply the face. Okay, so if this is your face, the external carotid artery will go and supply your face. Okay, and the internal carotid artery is responsible for completing the circle of Willis. Okay, so that's what it is. Okay, so that's exactly what's happening over here. So you have the internal carotid arteries. Okay, the internal carotid arteries are coming from over here. Okay, so let's say these are your internal carotid artery. Okay, and they're coming all the way up, all the way from your neck. And what's happening is from the internal carotid arteries, you have two major branches, two major and two very important branches. This one branch that is going away from the internal carotid artery, and even on this side, this branch is your middle cerebral artery. Okay, the portion of the brain that is highly responsible because middle cerebral arteries has a large area of blood supply. Okay, middle cerebral artery, and Another one that is going away from over here. From this side is your anterior cerebral. Okay, this side is your anterior cerebral artery. Let me just draw it a bit better. 1 second. Okay, and anterior cerebral. Okay, so this purple one represents anterior cerebral artery. Okay, anterior cerebral artery. Okay. Now what happens is the internal carotid artery over here. Now we are done with all the major arteries of the circle of Willis. Now all we have to do is we have to connect the branches, and the way that the branches are connected, it's not that you have to do it. It's already connected. Okay, so the connection of, okay, let's write this. Okay, so this is your internal carotid artery. Okay, and the way the connections usually happens is that the internal carotid is connected to the posterior cerebral artery, okay, by posterior communicating artery, okay, PCOMA, posterior communicating artery, and the anterior cerebral arteries, both of these anterior cerebral arteries, they are connected to each other. They are connected to each other by anterior cerebral arteries. Okay, they're connected to each other by anterior cerebral arteries, and this is known as, I mean, they are both connected to each other by anterior communicating arteries. Okay, not anterior cerebral. Anterior cerebral, both of the anterior cerebral arteries are connected to each other by anterior communicating artery. Okay, they are connected to each other by anterior communicating artery. If you have completed this diagram up till now, okay, you have completed 99% of the diagram. The last 1% is a very important 1%, and last 1% is these branches from the MCA. Okay, the MCA gives off some major fine branches, and these branches are really important because these branches are your lenticulostriate arteries. Lenticulostriate arteries are the arteries that are responsible for majority of the blood supply, and then one of the most major arteries that is responsible for stroke and ischemia. Okay, so have you guys understood the circle of Willis? And this circle over here, all the way in the middle, this circle is known as the circle of Willis. Okay, so have you guys understood this? Have you guys understood this? Okay. Okay. So what I'm going to do is I'm going to give you guys 1 minute. Okay. I am going to give you guys 1 minute. After 1 minute, we will come back and I will draw it out and you will help me draw this diagram by myself. Okay. And I will need the participations of how many doctors? Let's see. One doctor for this one. 1, 2, 3, 4, 5. 5. Okay. So at least I would need the participations of 5 doctors, 5 volunteers who would be happy to volunteer to help me complete the circle of Willis. Okay. So you guys get exactly 1 minute. Okay. So is everyone ready? Okay. So who are the volunteers, please? Who are the volunteers? Okay. Okay. Dr. Garbasi. Then who else? Dr. Uday, Dr. Hussein, Dr. Iman, and last one. Anyone? Anyone? Another one, please. No one else? Okay, Dr. Hassam, thank you. Okay, good. Okay, so let's start with our diagram for the circle of Willis, and you guys will help me complete it. Okay. Okay, so who were the doctors? First of all, we had Dr. Karbasi, and Dr. Karbasi will help us identify the beginnings of the circle of Willis. Okay, so Dr. Karbasi, if you can, please, you have the liberty to unmute yourself.
Okay, can you hear me?
Okay, I can hear you. Okay, so first of all, what we're going to do is we're going to draw it all the way from the heart. Okay, so first of all, we have the heart over here. Okay, and then from the heart, we talked about the fact that arteries are coming off. And what is the name of this artery that is coming off all the way over here?
Well, that's the aorta, and then we have the
Correct. Okay, and this is the right side and the left side. Okay, and in the right side, what is the name of this branch?
brachiocephalic trunk,
Encephalic trunk gets divided into your right
subclavian artery, and internal communicating artery, right?
right common carotid and right subclavian. Okay, and then this is the left side, and the left side I have left subclavian, right?
Right.
The
Yes.
left subclavian and the left common carotid. Okay.
Right.
From both of these subclavian arteries, you have the right subclavian and the left subclavian. What is the branch that starts with the circle of Willis? That starts the circle of Willis?
With the vertebral artery, with the right vertebral and left vertebral.
Okay, good. So we have the vertebral arteries which are coming together. Okay, and then they join. Okay, and what is the name of this artery?
Basilar artery,
Okay, basilar artery. And what is the name of this artery?
anterior spinal artery.
Anterior spinal artery. Okay, good. Okay, good. Thank you so much, Dr. Karbasi, for performing.
Thank you.
You're welcome. Who was the next physician? Dr. Hussein, I suppose. Can you hear my voice? Please have the liberty to unmute yourself so that you can complete the diagram.
Hi.
Hi, how are
Yeah,
you?
I'm here. Yeah.
Good, I'm very good. Thank you for asking. Okay, so what we're going to do is we have just learned that these are our two vertebrals. This is our anterior cerebral. This is your basilar. Okay, and then,
Basilar.
okay, and this basilar artery, this end.
Divided to right and left posterior cerebral artery.
Okay, so these are our right and left posterior cerebral arteries. Okay, I'm just going to identify the major branches: the vertebral, anterior spinal, and this is your basilar. Okay, and then after this, we talked about some cerebellar branches. And what is this branch over here that is coming for this?
Superior cerebral artery.
Okay, superior cerebral artery.
Cerebral
Okay.
artery.
What is the blood supply that is coming from over here that is responsible for this?
Anterior inferior cerebral artery.
Perfect, anterior inferior cerebral artery, and then
from the vertebral posterior inferior cerebral artery.
okay, so ICA and PICA. Okay, good, very good. And last one is, what is these smaller branches that we talked about? Remember we talked about
pontine
lateral pontine arteries or
lateral pontine arteries. Yeah.
Very good. Okay, thank you, Dr. Hussein.
Okay, welcome.
Well, the next physician, I suppose, was, who was it? Dr. Uday? No. Yes, it was Dr. Uday. Okay. So, Dr. Uday, would you unmute yourself and participate, please?
Okay. Yeah.
Okay, perfect. So we are more or less done with this segment of the circle of Willis. The next segment that we were going to go for is this one over here. Okay, and what is this major branch that is coming that will complete the circle of Willis? This is coming from the heart.
Carotid artery.
Right and left internal carotid arteries. That is probably good. And if this is the supply to the brain, where does the external carotid artery provide its blood supply?
It supplies the face.
Yes, it supplies the structures of the face. That is very good. Okay, then so over here we have this big artery that is going to each parts. Well, what is the name of these arteries?
Middle meningeal artery.
This is middle cerebral artery.
Cerebral artery, sorry.
Middle cerebral artery. Okay, good. And what is the name of these arteries that are coming from over here from these two
anterior, left or right, anterior
cerebral artery. Okay, good. Thank you so much, Dr. Uday, for performing. Who is the next physician? The next physician was Dr. Iman, if I'm not wrong.
Yes.
Okay, good. And would you help me connect the dots right now? So what is the artery that is responsible for connecting this one and this one?
Posterior communicating artery.
Posterior communicating artery. Okay, so this is posterior communicating artery. Okay, and what is the artery that is responsible for communicating these two?
Anterior communicating artery.
Anterior communicating artery. Okay, thank you, Dr. Iman, for performing, we have the next physician, which is Dr. Hassam. Dr. Hassam, would you be kind enough to tell us what is the name of these arteries over here?
Yes, doctor. Lenticular striatal artery.
Okay, lenticular striatal arteries. Okay, that's what it is. Okay, so that's mostly everything that you have learned from the Circle of Willis. Are you guys confident that you guys can draw this by yourselves? Everyone? First of all, thank you, Dr. Hassan, for performing. Okay, so this should be very easy for you now that you understand where these arteries are coming from, what they do. Okay, so next time you see the Circle of Willis, you should be feeling extremely confident. Okay, that's what it is. Okay, let's go back to our text. Okay. Okay, good. Okay, good. So that's exactly what we have just discussed. Okay, we have just discussed the cerebral, the cerebral arteries, where they come from, how they branch with each other, and perform and complete the Circle of Willis. Okay, Circle of Willis. Okay, that's what it is. Okay, next one. Next one is we are going to study about the dural venous sinuses. Okay, we are going to study about the dural venous sinuses. And for this one, what I would like to do is instead of drawing another diagram, since the dural venous sinuses are not that high yield, okay, we would just use this diagram over here. Okay, so what are the dural venous sinuses? The dural venous sinuses are basically your venous or vein or venous blood supply or blood drainage, right? So these are large venous channels that runs through the periosteal and meningeal layers of the dura mater. So the dura maters have two layers, periosteal and the meningeal layers, and they run in between them. Okay, and what happens is they drain the blood and they receive the CSF. So if you guys remember that we talked about this yesterday, that the cerebrospinal fluid is made from the choroid plexus, which are specialized ependymal cells, and they are absorbed by the arachnoid granulations. And after they're absorbed by the arachnoid granulations, they drain into the they drain into the dural venous sinuses. And from the dural venous sinuses, they go to the internal jugular vein, and from the internal jugular vein, they help and they drain the fluid mixed with blood in the heart. Okay, so what's happening is you have this. So first of all, let's track the whole thing. Okay, it's not that important to track the whole thing, but what's happening is you have the superior sagittal sinus. Okay, all the way coming over here, and what this does is it comes to the confluence. Okay, so this is the confluence. Confluence is basically the meeting point of all the important dural venous sinuses. So you have the superior sagittal sinus. Okay, and then after that you have the inferior, which is actually a bit lighter in color because it's coming from all the way down. So inferior sagittal sinus, which comes all the way over here into the confluence. Then you have another vein that is the great cerebral vein of Galen, which is also coming all the way from over here. And what's happening is just try to understand that most of the venous sinuses are coming together and they are forming the confluence of the sinuses. After they form the confluence of the sinus, what happens is you also have the transverse sinus which is coming all the way, and after they form the confluence of the sinus, they go to the occipital sinus. Okay, they go to the occipital sinus, then they go to the sigmoid sinus. After they go to the sigmoid sinus, they go to the internal jugular vein, and then they drain it over there. Okay, so is it important for you to understand the drainage of the dural venous sinuses? My answer is no. For your purpose of your exam, you will not receive questions on when they will ask you that how is the venous drainage of the brain, how is that taking place. Okay, but what they will ask you is if you understand that this thing over here, that the superior sagittal sinus is the main location of CSF return. So the CSF, the cerebrospinal fluid, after they're absorbed by the arachnoid granulations, this is the sinus where they come and then they drop the superior sagittals. They drop the CSF in. Okay, that's one thing that you have to know. Another thing that you have to know is that where do all the sinuses meet? All the sinuses, they meet at the confluence of the sinuses. Okay, that's another question. Next one is, what is venous sinus thrombosis? Venous sinus thrombosis, this is a clinical question. Okay, and this is high yield for your exam. Okay, so venous sinus thrombosis, they prevent with signs symptoms of internal intracranial pressure. Okay, so if you have a patient with venous sinus thrombosis, you will have signs symptoms of intracranial pressure, that is headache, seizure, papilloedema, Okay, and what this is the venous sinus thrombosis is that there's thrombosis of the veins over here, and there's another high yield reason for this thrombosis to take place, and that high yield reason is a hypercoagulable state, and the hypercoagulable state is due to pregnancy, OCPUs, and factor V mutation. Okay, so what happens in venous sinus thrombosis? You have patients with increased intracranial pressure. And why does it happen? This can happen due to hypercoagulable states. That's all you have to know. Okay. Is everyone clear? Okay. Okay, so can we take a small break for 10 minutes before we move forward? Okay, all right. Okay, let's take a break on 10 minutes. We'll come back. Okay, is everyone back from their breaks? Is everyone back from their break? Can you guys hear my voice? Okay, good. So far, how do you find neurology? Good, bad, hard, easy? How do you guys find neurology? Fine, okay. If everyone is ready, then I would like to proceed forward. Is everyone ready? Okay, let's do a small revision of our lateral of our ventricular system that we talked about in the previous lectures. Okay, so let's do a small revision of the ventricular systems. Okay, give me 1 second, please. Okay. So let's talk a little bit about the ventricular systems. Okay, so the ventricular system. So first of all, we have the choroid plexus. Okay, so choroid plexus are specialized ependymal cells. Where do the choroid plexus drain the CSF? In which ventricle? From in which ventricle? That ventricle. From that ventricle, which ventricle does it go to? Ventricle. Which ventricle does it go to? Third ventricle. Third ventricle. Third ventricle. And which foramen does it go through? From the lateral ventricle to the third ventricle. What is the name of the foramen? Is foramen of Monro. The name of foramen is foramen of Monro or foramen of Monro. Okay, and from the third ventricle to the fourth ventricle, which pathway do they use? Which pathway do they use? Foramen of? No, from the, so my question is, from third ventricle to the fourth ventricle, which pathway do they use to go from the third ventricle to the fourth ventricle? Yes. Okay, answer is cerebral aqueduct. Very good. And fourth ventricle, they go subarachnoid space. Okay, and they go to the subarachnoid space via the foramen of Luschka and foramen of Magendie. Okay, so and the Luschka. Okay, so foramen of Luschka, L for lateral, and M for Magendie and M for medial. Okay, so you have the lateral foramens and the medial foramens, and the medial foramens are the ones which are important for the median drainage. Okay, so that's what it is. Okay, and from the subarachnoid space, where are they absorbed into? Where are they absorbed from the subarachnoid space? Who absorbs the CSFs? Arachnoid granulations, and from the arachnoid granulation, where do they go to? Where do they go from the arachnoid granulations? Can you get some answer, please? Superior sinus and then the dural venous sinuses. That's exactly what it is. So you guys have, okay. So this is basically the ventricular system. Okay. So you guys have just explained the whole thing. You guys have just explained the whole thing. So that's that. Okay. So sometimes I wonder if you guys have already taken the step and just doing the lectures just for fun or something, because you guys know most of the things even before we discussed the systems. Okay, have you guys already taken your USMLE step 1 and are just wasting time? No, hopefully not. Okay, that would be me stupid. Okay, so the reason why I said that is because you guys are starting to think ahead of the book, and you guys have finished the ventricular system even before we have read the ventricular system. So this is exactly what it is. Okay, we won't go into any more details because we have touched all the texts from the ventricular system. Okay, we have touched all the text on the ventricular system. And if we have to look a little bit more of the diagrams, first of all, you have the choroid plexus. From there, it goes to the lateral ventricles. From the lateral ventricles, it goes to the third ventricle by the cerebral aqueduct. From the third ventricle, it goes to the, I'm sorry, from the lateral ventricle, it goes to the third ventricle by the foramen of Monro. And from the third ventricle, it goes to the fourth ventricle by the cerebral aqueduct. And from the fourth ventricle, it goes to the subarachnoid space by the Luschka and Magendie. And then from over there, they get absorbed into the choroid. They get absorbed into the arachnoid granulations. Okay, so that's what it is. Okay, so any more questions from the ventricular system? Do we have any more questions from the ventricular systems? Okay, no. Okay. Okay, so the next thing that we will be talking about is the brainstem. Okay, the next thing that we will be talking about is the brainstem, and there is some important things that we have to talk about. Okay, so for this, what I'm going to do is I'm going to I'm going to talk about a diagram. Okay, and 1 second. Okay, okay. Okay, so we will be talking about the brainstem. Okay, so the brainstem is basically what are the three things that make up the brainstem? I'm pretty sure you guys already know. I'm still asking you to see if everyone is on the same page. What are the three structures that make up the brainstem? Medulla, midbrain, pons, medulla. Okay, midbrain, pons, and medulla oblongata. Okay, medulla, pons, and medulla, pons, and midbrain, pons, and medulla oblongata. Okay, okay, so that's what it is. Okay, so what we are going to do is we have some important structures which are related to the brainstem, and it's heavily tested in your USMLE step 1, and that diagram is extremely important. Okay, so what we are going to do is we're going to see if we can draw the diagram on our own and break it down so that it's easy for you. Okay, okay. So we are just going to draw a brain. Okay, nothing else. Okay. So the first thing that we are going to do is, after we have this small border of the cerebral hemispheres, if you look at the brain from the underside, okay, the first structures that you see, okay, the first structure that you will see is that's coming all the way from over here. Okay, we have one coming from over here, and this is your olfactory bulb. Okay, this structure is your olfactory bulb. Okay, olfactory bulb is basically your CN1. Okay, so olfactory bulb is CN1. Okay, that's what it is. Okay, next one is okay, next one is the olfactory bulbs over there. And then after the olfactory bulbs, okay, we're just going to use another color. We have another structure over here. Okay, we have another structure over here which goes like this. Okay, and then okay, okay, and this structure over here, okay, this structure over here beneath the olfactory bulb, this structure is the optic chiasm. Okay, so far you guys know what the olfactory bulb is and what is the optic chiasm. Okay, so this is the optic chiasm. Okay, and okay, then the next one is we have to, what we have to do is we have to draw the pons, and then we have to draw the portion of the spinal cord. Okay, so first of all, let's draw a little, let's draw the pons. Okay, first of all, let's draw the pons, which looks somewhat like this. Okay, like a cone of ice cream. Okay, okay, so the pons. Okay. And there are some extremely important structures which are coming off from the head of the pons. Okay, and these structures are very high yield, and they are heavily tested whether you can identify these structures or not. Okay, so if this is the pons, so the first thing that is coming off from this head of the pons, okay, this one, this is your ophthalmic, this is your oculomotor nerve. Okay, so CN3. Okay, so CN1, CN2, and then we have CN3. Okay, then the next nerve that is coming off from over here, okay, this is CN4. Okay, this is CN4. Okay, then the next nerve that is coming from over here with the 3 branches, this is CN5. Okay, so far we have 12 pairs of cranial nerve. So we have drawn 1, 2, 3, 4, and 5. What did we draw? We drew 2 cerebral hemispheres, optic chiasm, olfactory bulbs, and 3, 4, and 5. Okay, so trigeminal nerve. Okay, so that's what it is. Now the next thing that we have to do is, so this is the pons, and then the next thing that we have to do is we have to form a portion of the medulla. Okay, what we have to do is we have to draw a portion of the medulla. Okay, so what we are going to do is we are just going to draw the medulla. Okay. Okay, over here. Okay, so this is a very rough diagram of the medulla. Okay. Okay, so that's what's happening over here. Okay, so excuse my drawing skills. Okay, so what's happening over here is, first of all, so you have the 3 nerves that is coming from the head of the pons. Okay, and then you have these nerves which are coming off in sequences. Okay, so this is first nerve that is coming from the head of the medulla. This is CN6 or abducens. Then obviously the nerve after that, this is CN7. Okay, and then the nerve after that, that is coming from over here, this is CN8. Okay, and then after that you have, these another nerve, CN9, and then you have CN10. Okay, and then you have CN11 and CN12, as simple as that. Okay, so you see a 9, 10, 11, 12, and then the same way 9, 10, 11, 12. Okay, let me see if I drew the thing properly or not. Okay. Okay, so basically that this is the structure which we are trying to learn. Okay, so this is what it is. Okay, 9, CN9, CN10, CN11, and CN12. Okay, so that's what it is. So far, did you guys understand how the cranial nerves are coming off from the brainstem? Okay. Is everyone clear about how these structures are coming off? Is everyone clear about how these structures are coming off? Okay, good. So the next time you guys see a question, okay, what I would do is, instead of asking you that, I'm going to make the question myself. Okay, very easily. Okay, what I'm going to do is roughly I'm going to draw. Okay, so what is the name of this nerve? Fast answers, please. Okay, good. What is the name of this nerve? Fast answers. Okay, what is the name of, okay, then we will, okay, over here. Okay, now what is the name of this nerve? Okay, after that, what is the name of this one and this one, and then this one and this one? CN4, CN5. Okay, and then we will draw. Unfortunately, we're a bit out of space over here. Okay, and then what would happen is the nerves that comes out in sequences are one from over here. What is the name of this nerve? One that is coming from over there. What is the name of this one? Okay, then what is the name of this one? And then 9, 10, 11, and then 9, 10, 11, and 12. 12, we need that. Okay, unfortunately, we're out of space. So very roughly, very extremely roughly, this is what we have drawn. Okay. So the thing is, as you can see that over here, the third cranial nerve, this looks like this is coming off from the pons. Okay, so what happens with the third cranial nerve is that the third cranial nerve, it actually on a coronal section of the brain, this nerve will look like it's coming off from the pons, but what happens is this nerve, it actually comes off above from above the pons, and so does the fourth. So what happens is you have let me take another okay, so you have this segment. Okay, so you have this segment of the brain. So this is the part of these are the cranial nerves which are coming off from above the pons. So although this is third and this is fourth, they look like they're coming off from the pons. They're actually not coming off from the pons. Okay, but if you view the cadaveric brain, if you cut it off and you try to see the structures, they will give you a false perception that they're coming from the pons, but they're not. So if this is 1, 2, 3, 4, so there's 1, 2, 3, 4, these 4 nerves. The first 4 cranial nerves, they're actually coming from above the pons, okay, and then the next nerve, that is 5, then 6, then 7, and then 8. Okay, so let me just draw a border really quick. So 5, 6, 7, 8, and 5, 5, 6, 7, 8. Okay, so over here, let me see if that's what it is. Okay, so these 4 nerves, so if we have 5, 6, 7, and 8. Okay, what these nerves do is they exit at the level of the pons. Okay, so once again, 1, 2, 3, and 4, these are above the pons, and then 5, 6, 7, 8, they exit at the level of the pons. Okay, after that we have which nerves we have? 9, 10, 11, 12. Okay, 9, 10, 11, 12, and these nerves, 9, 10, 11, 12, these nerves are present in the medulla. As we just talked about, this is the medulla, right? So this is the nerves which are present at the medulla. So if anyone asks you what are the nerves that exit at the level of the pons, the nerves that exit at the level of the pons are 5, 6, 7, 8. The nerves that are present above the pons, 1, 2, 3, 4, and the nerves that are present below the pons and that exit at the level of the medulla, the nerves are 9, 10, 11, and 12. Is that understood? Did you guys understand? Okay. Okay. So that's what it is. Okay. Next one. Okay. So next one is okay. So what we are going to do is we're going to see if we could have learned this thing perfectly or not. Okay. So as we just talked about, 4 nerves are above, 4 nerves exit at the level, 4 nerves in the medulla, and this is the one which we didn't talk about. This is 4 nerves are medial. That is 3, 4, 6, and 12. So 3, and then you have 4, and then you have 6. Okay, and then you have verse 12, 12. Okay, so these are medial nerves. So these are the ones which stays in the middle. Okay, so these are the one which stays in the middle. Okay, this is not relatively very important as long as you understand. Okay, let me see if I can one second. Okay, so you can see some, okay, but this is not the actual picture that I was looking for. Okay, let me see. Okay. Okay, so this is somewhat understandable. This is somewhat understandable. Okay. So right now, okay, can you guys give me just 1 second, please? 1 second. Okay. All right. So if we look at my apologies for the minor inconvenience. Okay. So if you can look at this diagram, could you guys name this cranial nerve? What is this cranial nerve over here? Let's see if you guys understand. Very good. What is this nerve over here? Okay. And if this is the pons, okay, what do you think this nerve is over here that is coming off above? Okay, you can see more of the other nerves. Okay, they're not that common, but what I will do is I will provide the actual image that you are provided with in your exam, and I will try to break it down for you. Okay, but you guys get the idea about how you guys will be asked questions. The way you guys will be asked questions is you guys will be told about a nerve. Okay, you guys will be told about a nerve, and then you guys will have to identify it with the labels. They will label it down, and then they will identify which one is the one. Let's say, for example, a patient comes to you with let's say with a problem with the patient has ptosis. Okay, the patient has no okay, so the patient has diplopia, not ptosis. So let's say this patient of yours, he or she has diplopia, and the patient has a problem with lateral movement of the patient has a problem with the lateral movement of the eyeballs, right, or of the eyes, and the eyes are medially deviated. Okay, so we know that if this is the type of question, then which of the following nerves are affected in this patient? If there's a patient with lateral problems and the eye medially deviated, are you guys sure it's third? The patient cannot turn their eyeballs laterally. The patient cannot move their eyeballs laterally. What is the muscle responsible for the lateral movement of the eye? Lateral movement of the muscle. LR. Who applies LR? Lateral rectus abducens. Okay. So which cranial nerve is at fault? 6. So over here, after they ask you to identify what is the nerve, and after you identify it's cranial nerve 6, then you guys will have to label it from this diagram over here, that which nerve they're talking about. Okay, so let's say this will have A, this will have B, this will have C, this will have D. And if you do not understand this diagram, you guys cannot identify properly which nerve they are asking about, and that's how you guys will receive your question. Is that understood? Is that understood? We'll see questions. Okay. Okay. All right. Good. Next one. Next one is brainstem. Okay. So the brainstem. Okay. What happens with the brainstem is over here. What we have is this is a lesser yield high yield diagram. Okay. So just for your understanding. So you have these two thalamus. Between the thalamus, you have the third ventricle. Then you have the pineal gland, superior inferior colliculus. Okay. And then we have the cerebral peduncles, through which the transmissions are occurring from the cerebellum to the spinal cord from the brain, and that's what it is. Okay, and what are the functions of the superior and inferior colliculi? Okay, superior colliculi are basically they're involved with eye movements, and inferior colliculi are involved with auditory. We will be learning more in details about the superior and inferior colliculi when we talk about the auditory pathway and the eye pathway. Okay. So that's what it is. So I don't want to spend more time over here because this diagram is not extremely high yield. Okay, I want to keep on moving on. Okay, next one. Okay, next one which I want to talk about are the cranial nerve nuclei. Okay, so cranial nerve nuclei, that where are the nucleuses of the cranial nerve present in? Okay, so first of all, you have the nuclei of the third and fourth cranial nerve. Okay, the third and fourth cranial nerve. I talked about the fact how the third and fourth cranial nerve, are they above the pons or they below the pons? Above or below the pons? I mean, are they coming from the midbrain or are they coming from the pons? The nucleus, are they present in the midbrain or are they present in the pons? Midbrain. Okay, so this is basic understanding that if it's present above the pons, then the nucleus is in the midbrain. Okay, the nucleuses that are present in the pons are the ones that we talked about, right? That we said that 5, 6, 7, 8. These are the 4 cranial nerves which exit at the level of the pons. Then obviously the nucleus of these cranial nerves has to be at pons. Okay, and then we talked about another nerve, group of nerves, there's 9, 10, 11, and they exit at the level of the medulla. So the nucleus of them, of these nerves are present in the medulla. Okay, so that's what it is. Okay, another one is, if you have, if you see this diagram over here, okay, the lateral ones, okay, the lateral part, okay, these ones, okay, so these parts are the nucleus which stays more laterally, okay, so basically all the nucleus which stays on the lateral side, okay, so the lateral nucleuses are more of your sensory nucleus, and the nucleus which stays in the middle. So you, as you can see that the medial nucleus, for example, CN6, CN5, they all innervate certain muscles. Okay, so those are muscular innervating nucleus, and those nucleus, they stay in the middle. So even if you forget which nucleus, let's say you get a diagram like this in your exam, right? Let's say you get a diagram like this in your exam, okay, and you're not sure which nerve is doing which function. If you can just remember that the nucleuses on this side are responsible for sensory function, and the nucleus for over here are responsible for motor function. Okay, then if they're asking to identify you, if they're asking you to identify which cranial nerve is doing the function, at first all you have to do is figure out if they're talking about a sensory nucleus or if they're talking about a motor nucleus. If they're talking about a motor nucleus, then they will be present more in the center. If they're talking about a sensory nucleus, they will be present more at the lateral side. Okay, that's what it is. Is it clear? Is it clear? Is it clear to everyone? Have any questions? Okay, good. Okay. Okay, another diagram. Okay. Okay, another diagram. Okay. So what we're going to do is we're going to learn about the cranial nerves and the cranial nerve vessel pathways. Okay. And what I would do is I am pretty sure you guys have already learned about this. So instead of learning, we will do a review. Okay. We will do a review. So very roughly put, this is your brain over here. Okay. This is the anterior cranial fossa, middle cranial fossa, and this is the posterior cranial fossa. Okay. So first of all, I will name the openings, and you guys will tell me the nerves which are exiting. Okay. First of all, we have these dots on each side, and this opening is known as the cribriform plate. What is the nerve that exits the skull or base of the skull? And it's E because it's a factory nerve. Okay. Next, we have this two over here. This is your optic canal. And what exits the base of the skull through the optic canal? Okay, optic nerve and also ophthalmic artery. So do not forget ophthalmic artery. So optic nerve and ophthalmic artery. Okay. Okay. Next one. Next one is another one over here. Okay. This is known as the superior orbital fissure. Superior orbital fissure. What are the nerves that exits through the superior orbital fissure? Very easy. Please go in sequences. So we have 3, 4, 1, and 6. We have, so 3, 4, 5, 6, 3, 4, 5, 6. And so this is 1, this is 2, and over here we have 3, 4, 5, or V1 and 6. Okay, superior orbital fissure. So these are the nerves that are exiting through the superior orbital fissure. Next one. Next one is over here. Okay. Okay, over here. Okay. And what is the nerve that is exiting through over here? Oh, sorry. The name of this foramen is foramina rotundum. Foramina rotundum. Okay. And V2. Next one. Okay, foraminal-rotundum. There is V2. Okay, next one is, what is the nerve that is exiting through foramina ovale or V3? Okay, V3. Good, very good. And then we have another high yield foramen, that is foramen spinosum. Okay, which cranial nerve exits through foramen spinosum? Which cranial nerve exits foramen spinosum? Do not look at picture in the book. Are you guys sure that no nerve exits the foramen spinosum? Okay, very good. So that is what it is. No nerves. Okay, foramen spinosum has no nerve. It has only one artery. That artery is middle meningeal artery. Okay, MMA. Okay, good. Next one. Next one is, now we will go to the posterior fossa. In the posterior fossa, we have these two foramens over here. This is your internal auditory meatus. What are the nerves that exits through the internal auditory meatus? 7 and 8. Okay. Next one. What is the nerve that exits through this one? This is the jugular foramen. This is the jugular foramen, and this is a very high foramen through which a lot of nerve exits. 9, 10, 11, and we also have a vein, and that vein is jugular vein. So we have 9, 10, 11, and jugular vein. Okay, next one. Next one is the big canal over here. Okay, this one is the big canal. This big canal is known as the foramen magnum. What are the nerves that exit through the foramen magnum? No, it's not 12. Okay, part of E11 or spinal part of CN11, and there's another small channel over here. Okay, what is the nerve that exits through here? CN12. That is known as the hypoglossal canal. Okay, so that's what it is. So this is your cranial nerves, and basically the nerves which exit at these spaces. Okay, so that's what it is. The nerves that exit at these spaces are these cranial nerves over here. Okay. Okay. Next one. Are you guys clear about? So did you guys understand about all the cranial nerves and at which point they exit which through which foramen? Okay. Next one. Okay. Next one is, what is the function of the first cranial nerve? Does anyone have any idea? Smell. That's easy. What is the second cranial nerve? Vision or sight. That is very good. Okay. What is the function of oculomotor nerve? Let's see if anyone has any idea. What is the function of the water that are innervated by ocular nerve? Okay. Guys heard about SO4 and LR6? SO4 and LR6. Okay. SO4 and LR6 means that superior oblique is supplied by the fourth, and lateral rectus is supplied by the sixth, and all the other muscles of the eyes are supplied by the third. Okay, so SO4 and LR6. If anyone have not heard of SO4 and LR6, please write it down in your book. SO4 and LR6. Next one is, what is the function of fourth cranial nerve? Fourth cranial nerve. SO meaning superior oblique. Okay. Okay, good. S4. We just said this. What is the function of the trigeminal nerve? Let's see who has an idea. Trigeminal nerve. What is the trigeminal nerve? Feels sensations, and also it supplies muscles. It also supplies some muscles. Muscles of mastication. That's good. Okay, good. What is the muscle supplied by the sixth cranial nerve? L. Okay, what are the functions of the facial nerve? What are the functions of the facial nerve? Facial movements and face and taste. Okay, good. Okay, so that's what it is. Okay, it also supplies two glands. What are the names of the glands that are supplied by facial nerve? Okay, okay. So remember this. Okay, submandibular and sublingual. Submandibular and sublingual are supplied by facial nerve, okay, and parotid glands are majorly supplied by. Who supplies the parotid glands? Let's see who has an idea. Who supplies the parotid? Right. So it's C and 9. Okay. C and 9. So this is a very high yield question about from USMLE. Okay. A lot of the students will answer that the parotid glands are supplied by the seventh cranial nerve. The parotid glands are not supplied by the seventh cranial nerve. The parotid glands are supplied by the ninth cranial nerve. Okay, that's what it is. Okay, what is the function of the eighth cranial nerve? What is the function of the eighth cranial nerve? Very good. What apply from of the ninth cranial nerve? And we talked about this before. What is the function of the ninth cranial nerve? Okay, from where? Which part of the tongue does it carry taste and general sensations? Okay, and do you guys remember we talked about the ninth cranial nerve in the regulation of blood pressure? Okay, glossopharyngeal nerve. We talked about this. We talked about some sinuses, baroreceptor and chemoreceptor. That is very good. Carotid body and chemoreceptors. Okay, okay. Okay, next one. Next one is your 10th cranial nerve, that is vagus nerve. And we talked about the fact how the vagus nerve is involved with sensations from the posterior part of the tongue all the way behind the posterior one third. Okay, and is the vagus nerve a sympathetic nerve or a parasympathetic nerve? Parasympathetic. Okay, good. And another thing is there is a reflex of the body known as the cough reflex. Do you guys remember we talked about all the different types of cranial nerve reflexes in our UWorld notes? Do you guys remember that we talked about UWorld notes, cranial nerve reflexes? Okay, over there we also talked about a reflex known as cough reflex. Okay, we talked about the fact how the cough reflex has the involvement of the vagus nerve. Okay. Okay, good. Next one is accessory nerve. Accessory nerve. Okay, accessory nerve. What are the two muscles that are supplied by the accessory nerves? What are the two muscles that are supplied by the accessory nerves? And trapezius. Okay. Okay. Next one is the function of the 12th cranial nerve? Tongue movement. Okay, movement of the tongue. Okay, and what are the muscles of the tongue? We talked about the muscles in the last lecture. You guys remember? Genioglossus, glossus, styloglossus, supplied by hypoglossal nerve, and except which muscle is supplied by which muscle, which is supplied by vagus. Very good. Okay, glossus, which is supplied by vagus. Okay, good. Now the next thing which I want you to do is okay. 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 So the thing is, there is some. Okay. So okay. So okay. So the next thing is a small mnemonic, which I want to discuss with you guys. This is the mnemonic which was used by first year, and the thing which I want to break this to you is, okay. So if you guys want to marry someone, okay, you guys are starting out in your residency careers. Let's say you find someone really nice, and then you also find someone who has a lot of money, but the first guy or the first girl that you guys find, okay, and that person has a bigger brain, and that another person has more money but less brain. Which type of a guy would essentially you as physicians go for? Because you guys do not need money. Hopefully you guys will earn a lot of money. Okay. But which type of person do you think you should go for? Okay. Okay. So the mnemonic is basically something like this, that someday marry money, but my brother says, my brother says big brains matter most. Okay. So how many words do we use? Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. Okay, so what is the mnemonic? The mnemonic is some say marry money, but my brother says big brains matter most. Okay, so that's what it is. The reason why we discussed that small story and that this mnemonic over here is you have 10 cranial nerves, and out of those 10 cranial I mean you have 12 cranial nerves, and out of those 12 cranial nerves, you either have some that are purely sensory, then you have some that are purely motor, and then you have some that both. Okay, so the next time you are confused about which nerve is what, which nerve is a purely sensory nerve, which nerve is a purely motor nerve, just remember this mnemonic. So if you write 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, after this, just after you write this down, write down the words some say marry money, but my brother says big brain matter most. Okay. So number 1 is sensory, number 2 is sensory, number 3 is mixed, number 4 is mixed, number 5 is both, number 6 is 1, 2, 3, 4. Number 6 is also more, very good. And then number 7 is both, and you guys get the idea. Okay, do you guys get the idea? This is exactly how you guys can answer confidently each and every time. Okay, you guys will be given a small you guys will be given a small page when you do your rough works. Okay, your rough handlings. Okay, all the things that are going through your head, you can jot it down and write it down in that page, and you guys can just write it down as fast as possible. If you guys receive a question, all you guys would have to do is spend 5 seconds to write this down. SSM, MB, MB, SBB, MM, meaning some say marry money, but my brother says big brain matter most. These are the ones how you can use to break down the cranial nerves. Okay, do we have any questions? Do we have questions? Okay. And with that being said, we are done with this whole table. Okay, we are done with this entire table. Okay, is it better now? Is it easy now? Did you guys understand how you should address the whole thing? Okay, we are done with everything. This is high yield. Okay, this table is high yield. We have discussed everything from this table. Okay, what are the names of the muscles? I mean the cranial nerves, what are their functions, what are the types, and we have discussed everything. Okay, so should we move forward? Should we move forward? Okay. So the next time you guys want to review the table, a table as big as that one, where all you have to do is read the functions and the mnemonics, how long do you think this will take you? How long do you think this will take you to read? 3 minutes, or 3 to 5 minutes at maximum. Okay, at maximum. So if you guys are confident, this should take you on exactly not more than 3 to 5 minutes to read the whole thing. Okay, so this is the whole point of our lecture, is that we can break it down. We try to break it down for you so that you can do the review and recall in the shortest period of time. Okay, so are we succeeding? Are we doing a good job? Is the pace of the lecture okay? Should we go faster? Should we go slower? Okay, okay, good. So are you guys confident with this table? If you guys are, then I would like to move forward. Are you guys confident? Okay, next one. Next one is vagal nuclei. Okay, next one are your vagal nuclei. Okay, so first of all, we talked about the nucleus of tractus solitarius. Okay, we talked about nucleus tractus solitarius, which is a which is a visceral sensory informative nuclei. We have taste and gut distensions. Okay, and the nerves that are involved with the nucleus of tractus solitarius are 7, 9, and 10. Okay, 7, 9, 10. And there's not really a lot of questions we will receive from these ones over here, but just try to remember this because we will be needing this knowledge in the future. So nucleus of tractus solitarius are your sensories are 7, 9, and 10, the sensory portions of the 7, 9, and 10. Okay, next one is nucleus ambiguus. Nucleus ambiguus are your motor, they help with the motor innervation, the pharynx, the larynx, and the upper esophagus. And the nerves that are involved in 9, 10, 11. Nerves that are involved are 9, 10, and 11. Okay, another nucleus is dorsal motor nucleus, and they send parasympathetic fiber to the heart, lungs, and upper GI. And obviously, the only parasympathetic nerve that is important for these things to happen are vagus nerves. That's it. Okay, so do not try to memorize this or keep this in mind as of right now. Okay, I will tell you guys how this knowledge will come into play in the future. Okay, okay, next one. Next one are your corneal nerve reflexes. And we already talked about the corneal nerve reflexes before. Okay, we have talked about the corneal nerve reflexes before. I mean, we have talked about the cranial nerve reflexes before. Do you guys want to discuss the cranial nerve reflexes again, or do you guys want to skip this part? Okay, we have talked about this in UWorld lectures. Okay, we have talked about this in our UWorld lecture. That's small review. Okay, everyone, let's see if you guys remember the cranial nerve reflexes. Okay, that's what we can do. Okay, so the first reflex is, as far as I remember, that's a corneal reflex. Okay, what is the efferent for the corneal reflex? What is the efferent for the corneal reflex? Very good. And what is the efferent? So corneal reflex is basically when you touch, the eye shuts down. Okay, and the sensory is via V1, and the motor portion is by the seventh cranial nerve. So that's one. Next one is your lacrimation or tear reflex. If you want to cry, I mean, if you touch the part of the eyes that are, let's say, if something comes in contact with your eyes, not only do you shut your eyes kind of get teared up, teary eyes. Okay, so that's a reflex. So what is the efferent for tear or lacrimation? What is the sensation of the eyes? And afferent, who carries the nerve? Who carries a signal? V1. Once again, it's the same thing, V1. And after that, what is the supply to the lacrimal glands? Okay, good. Next was jaw jerk reflex. Okay, so jaw jerk reflex is basically it's used for little babies. Okay, so which nerve is important for the reflex on the jaw? Which nerve supplies the jaw? V3, meaning mandibular division. And once again, which muscle will shut down or close the jaw? Muscles of mastication. And who supplies the muscles of mastication? Supplies the muscles of mastication? That's right, V3, not 7. 7 supplies the muscles of facial expression. Okay, CN7 is involved with supplying the muscles of the facial expression. Okay, so V3. Okay, next one is pupillary reflex. If you shine a light into one eye, the other eye's pupil will also constrict. This is known as pupillary reflex. So what is the efferent nerve for pupillary reflex? Two. What is the efferent nerve that will close the three? Very good. Next one is gag reflex. Gag reflex meaning that if something goes, let's say you swallow a piece of hair. Okay, a piece of hair is irritating the posterior portion of your tongue. Okay, and you try to gag it out, meaning you this is a vomiting reflex. What is the supply of the posterior portion of the tongue? Okay, and what is the efferent of the gag? Gag is the same thing. And once again, we have just talked about the cough reflexes. What is the nerve responsible for both afferent and efferent cough reflex? Okay. I'm pretty sure you guys have learned this. Okay, so this is exactly what we did. Okay, so can I get 1 minute? Okay, you guys can do a small read, and then I will come back. Let's just give me 1 minute, please. Okay, all right. So we are done with the cranial nerve reflexes. Okay, we're done with the cranial nerve reflexes. And right now what we would be doing is we would be going for the muscles of mastications. Okay. Okay, so muscles of mastications. Okay. So are you guys ready? Should I move forward? Okay. Okay, so muscles of mastication. So basically you have the mastication muscles, meaning the muscles that help you open and close the jaw. And the muscles of mastications, we talked about the fact how they are supplied by the trigeminal nerve. Okay, so that's that. And the muscles of mastications are basically masseter temporalis and medial pterygoid. Okay, masseter temporalis and medial pterygoid. Okay, and what they will do is they have used a mnemonic saying M's munch, and munching means closing the jaws. So M's munch meaning the masseter temporalis and medial pterygoid. These are the three muscles that help you close the jaw. And then you have one muscle that is lateral pterygoid. Okay, lateral pterygoid. And lateral pterygoid, what this does is the lateral pterygoid, they help you open the jaw. Okay, so the M's munch and lateral lowers. Lower means lowering of the jaw. And the muscle that helps with lowering of the jaw is lateral pterygoid. Okay, so that's that. Okay, next nerve. Next one is So did you guys understand medial temporalis and masseter, ems munch, and laterals? Next time, if you guys receive questions on which muscles help you open the jaw, what is your answer? Which muscle helps you open the jaw? Okay, so pterygoid muscle. Okay, so the lateral pterygoid muscle. Okay, that's what it is. Just keep in mind M's munch and lateral lower, then you guys should be good. Okay. Okay, next one. Next one is what we're going to do is we're going to study about the spinal nerves. Okay. So we have the spinal nerves, 31 pairs of spinal nerve. We have cranial nerves and we have spinal nerves. Spinal nerves are 31 pairs, cranial nerves are 12 pairs. Spinal nerves are your 8 cervical, okay, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Okay, so 8, 12, 5, 5, 1. That's what it is. 8, 12, 5, 5, 1. That's what it is. Okay. So try to remember these as numbers of your cell phone. Okay. 812, 551. Okay. Okay, 1 second. 5, 5, 1. Okay. 812, 551. That's what it is. So try to remember these as the numbers of your cell phone. 8, 12, 551, and 31 pairs. Okay. And what happens is the nerves that is between C1 to C7, they will exit above the vertebra, meaning that, okay, meaning that if let's say if C3 has to exit, they will exit above the third cervical vertebra. So if you have the second vertebra, and then you have the third vertebra, okay, so if this is C2, okay, this is C2 and this is C3. Okay, the nerves that will extend above the nerves that will extend in between C1 to C7 and C2 to C3 is between C1 to C7. So all these nerves will exit above the vertebra, meaning that the C3, if it has to exit, they will exit through over here. Okay, if the C2 has to exit, they will exit through over here. Okay, so that's what it is. Okay, and what will happen is the C8, what this will do, that the C8, if the C8 has to extend the C from C8, what this will do is they will exit, let's say this is 8, okay, C8. If the C8 has to exit from the C8 onwards, the nerves will keep on exiting below the vertebra. So above so from C1 to C7, the nerves will exit above the vertebra, and from C8 below, okay, they will exit below the vertebra. So if let's say this is T3, okay, and let's say this is T4, okay. So what is the name of this nerve? Let's say if this is the nerve that is exiting, what is the name of this nerve? This nerve, it's the level T3. That is correct. This nerve is T3. Okay, T3, not T4, because only C1 to C7 exit above the vertebra. So the nerve which exits between below T3 are the nerve that exit from T vertebra. Okay, did you guys understand? Is it clear? Is that clear? Okay, that's what it is. Okay, next one. Next one is we will talk about the spinal cord and the lower extent of the spinal cord. So in adults, the spinal cord will extend at the level of L1 to L2, and the subarachnoid space will extend to the level of the S2. Okay, the subarachnoid space will extend at the level of the S2, and the spinal cord would only be present in between L1 to L2. So if we have to do a lumbar puncture, the lumbar puncture is usually performed between L3 to L4 or L4 to L5. So between L3 to L4, okay, so it is L1, L2, L3, L4 to L5. So we do the lumbar puncture over here. Why? Because we do not want to do it over here because we can damage the spinal cord. Okay, so we do it at the level of L4 to L5. Okay, and the goal of the lumbar puncture is to do it to obtain CSF. And can anyone tell me a very basic indication of doing a lumbar puncture? A very easy question. What is the basic indication of doing meningitis? That is correct. Well, when you say a patient who has meningitis, we do a lumbar puncture because we want to study the CSF to see if it's a viral, bacterial, in some cases fungal. Okay, well, that's what it is. Okay, that's that. And what happens is when we do a lumbar puncture, there are some stages of structure that we have to go through in order to reach this level. Okay, so what are the structures that we have to go through? First of all, this is the skin. Okay, if you have to have a needle, they will first penetrate the skin. After they penetrate the skin, they will penetrate the fascia. Okay, over here, the fascia and the fat. And then next one, what they will penetrate is the supraspinous ligament. Okay, so you can see over here that the supraspinous ligament is over here. Then you have interspinous ligament. Okay, then you have ligamentum flavum. Okay, and then you have epidural space. And the ligamentum flavum is the question. So this is the question: is when you do lumbar puncture, you hear a pop sound. Which of the following structures is important for hearing that pop sound? Pop. Okay, you hear a pop sound. This is a question in UWorld. Okay, UWorld question. Which structure is responsible for that pop sound when you do the lumbar puncture? Let's see who has an idea. Who has the idea? Who knows what I'm talking about? Does anyone know what I'm talking about? Okay, do you understand? You are doing the lumbar puncture. You hear a sound that sounds a little bit like this, like something like that. Okay, did you guys hear that pop sound? Okay, hear from my microphone. This sound like. Okay, do you guys hear that sound? Okay, so which of the following structures is important for hearing, for making that sound? The structure that is important for making that sound is ligamentum flavum. So please write this down in your book because I think it does there. You guys will learn about this in UWorld, but I do not want you guys to miss any questions. So ligamentum flavum. Okay, and then the next one is an epidural space. This epidural space over here, and this is the space where we give our anesthesia. Okay, epidural anesthesia. Okay, and then the next one is epidural anesthesia is a local block. Okay, and we give the epidural block over here. Okay, then the next one is a dura mater and arachnoid mater, and then there's subarachnoid space. Okay, dura mater, arachnoid mater, and subarachnoid space. Okay. Okay. How can you remember this? Okay, so super fast glue. Okay, super fast glue sealed. Do you guys know what sealing is? What glue does? Glue seals. Glue does what glue does is glue seals break shut, right? So instead of writing SEALED, we will write SILED. Super fast glue sealed and strong. Okay, and strong. That's what we're going to do. Okay, you guys can use the diagram to remember the different structures, or you can use the mnemonic. Okay, so super fast glue, super for skin, fast for fascia, then sealed, SILED, S for supraspinous ligament. Okay, I for interspinous, L for ligamentum flavum, E for epidural space, D for dura mater, A for arachnoid matter, and an arachnoid matter, strong for subarachnoid space. Subarachnoid space. Okay, so again, what is the mnemonic? What is the mnemonic? What is the mnemonic? If you have a patient with lumbar puncture and the patient is coming to you with drainage of CSF fluid, what will you do? You will use a glue to seal that spot shut, and you will seal it strong. So what is the mnemonic, please? What is the mnemonic, guys? Can I get some answers, please? Voice. Super fast glue, sealed and strong. That is good. Okay, super fast glue, sealed and strong. So what happens when you get a lumbar? I mean, what happens when you have a small hole in your back from where CSF is being drained? What do? Do you use a glue or do you not use a glue? Fast answers, please. Do you not use a glue? Yes, you use a glue. Okay, this will help you remember the mnemonic. So what happens? What does the glue do? What does the glue? How can the glue help? Can I hear the mnemonic one, please? Because this is a very or USMLE. Okay, sealed. Remember that the spelling of sealed is SILED, not SELED. Okay, so sealed and strong. Okay, so use this mnemonic to learn about the layers of the spinal cord. Okay. Okay. All right. Okay. Is it okay if we keep the first aid up to here for today? Because now things will start getting complicated because we have to learn about tomorrow. Okay. Okay, so we can keep the first aid up to here. Yes, it's getting a bit too much for everyone. I can understand because whenever I see you guys responding very slowly, or when I see that I do not have enough responses from you guys, then I know it's an indication for me to stop. Okay. Whenever I ask you guys questions and it takes you guys some time to give me answers, then I immediately realize that it's about time that we should stop reading first aid. Okay. Okay. So that's what it is. Okay. Having said that, do you guys understand today's lecture? Because we talked about a lot of important, difficult things, but we have tried our level best. I have tried my level best to make you guys understand in the easiest way possible. Okay. Yes, it was the better days topic. Okay. So, and I want to thank you guys for putting your utmost attention to understand what I have been asking you to do and what the lecture is. Okay. So that's that. Okay. 1 second. Okay, so can we take let's say around 5 minute break before we start out with our UWorld notes for today, and then we can also do some. Okay, all right. Okay, so is everyone back from their break? Okay, let me see. Okay, good. So we are going to start with our UWorld notes right now. And having said that, I know a lot of you will leave. Okay, but please try to stay. Okay, so please try to stay during the UWorld notes discussion because during this discussion we talk a lot about some high yield informations, and reading the notes afterwards is not the same thing as being in the discussion is. Okay, so having said that, I expect you guys to stay, but then again, if you guys have things which you guys need to take care of, or because we know that our lectures can be a bit lengthy. Okay, because we take our time in making you guys understand whether you guys have learned all the high yield informations or not. So having understood that, if there is absolutely no way that you can stay, and if you have to leave, you're more than welcome to do so. But for the students who can continue and stay during the UWorld notes, it's highly appreciated. So that's that. Okay, and at the same time, while we discuss the notes, while we start writing the notes over here, um, please feel free to unmute yourselves, whoever wants to, and see if you can participate in letting us know whether you know the answers or not. And that will help me save time instead of going back and forth to the chat box to see who has answered and to see who has not answered. Okay. Okay. All right. Okay, 1 second. Okay. So does anyone know the complications? Okay, so we will be starting right now. Does anyone know the complications of long-term Sjogren syndromes? Sjogren syndrome. Anyone?
Lymphoma.
Non-Hodgkin lymphoma.
Oh, okay, so it's B cell lymphoma, non-Hodgkin's, and another one, long-term complications. So due to the decreased tear production, the patients can also get corneal ulcer.
Blindness.
Okay, corneal ulcer. Okay, next question. Next question is, what do you see in the histology of polyarteritis nodosa? What do you see in the histology of polyarteritis nodosa?
Fibrinoid necrosis.
Okay, so you see segmental thrombosis with, segmental transmural ischemia. Okay, my bad. My apologies. Says segmental transmural ischemia with fibrinoid necrosis. That's what you expect to see in a patient with polyarteritis nodosa. Okay, and okay. Next one. Next one is, what is the pathology behind the formation of ganglion cysts? What is the pathology behind the formation of ganglion cysts?
Make the food like I eat, same way. That's the secret, right?
Okay, so can you guys hear my voice? Okay, perfect. What we were talking about was the UWorld notes. I'm sorry I had to take a call. It was regarding my father. Okay, so where were we? Okay, let's see. Okay, so we were talking about the pathogenesis of the ganglion cyst, and now what is the pathogenesis of the ganglion cyst? What's happening with the ganglion cyst over here? Does anyone know? What is the pathogenesis of the ganglion cyst? Fluid filled swelling. Okay, so what's happening over here is that you have the destruction of periarticular tissues. Okay, you have the destruction of the periarticular tissues. Okay, next one. You have the destruction of the periarticular tissues, and that's exactly what's happening in ganglion cyst. Okay, next one. Next one is what is pseudogout? Okay, what is the problem with pseudogout? What do you expect to see in a patient with pseudogout?
Hypercalcemia.
Calcium phosphate.
So what do you expect to see in a patient with pseudogout? You see calcium
Calcium crystal.
Calcium phosphate.
phosphate crystals, phosphate crystals with neutrophil predominance. Okay, you see calcium pyrophosphate crystals with neutrophil predominance. Okay, and is it a negative beer infringement or positive beer infringement?
Positive.
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 Positive beer infringement. Okay, and okay, that's that. Okay, next one. Next one is anti-cardiolipin antibody. Okay, so if you have a patient with anti-cardiolipin antibody, will there be increase in PTT or decrease in PTT? Will there be increase in PTT or decrease in PTT?
Increased PTT.
Increased PTT. And what about the prothrombin time? Is the prothrombin time normal or not normal?
It's normal.
What is the PTT? Is the PTT normal or is the PTT not normal?
PTT normal, doctor, because the platelet only affected. Yes?
Okay, good. Good. Okay, so what do you expect to find in a patient with Burkitt lymphoma? What do you expect?
Jaw infiltration.
Okay.
And sky star appearance in bone marrow.
Very good. So what you see is you see a lymphocytic infiltrate with basophilic vacuolar cytoplasm. Okay, so you see lymphocytic infiltrate with basophilic vacuolar cytoplasm. Okay, that's what it is, vacuolated cytoplasm. Okay, as a result of this, what happens is you have the starry sky appearance. Okay, you have the starry sky appearance. Okay, once again. Okay. Next one is in sickle cell trait. What are the hemoglobins that are present in the sickle cell anemia?
Hemoglobin S. Hemoglobin A.
Hemoglobin A.
And
F.
After treatment.
Okay, so what's happening over here is that you have sickle cell trait patients have a hemoglobin S, which is around 10%. Okay. Then you have hemoglobin A, which is around 20%.
And hemoglobin F.
And then hemoglobin F, which is around 70%. Okay, that's what it is. Okay, next one. Next one is AML. Okay, and what do you see in a patient with AML? In the
rods.
Okay, so what you see is you cell blast cells with our rods. Oh, next one is okay. So what do you see? Okay, what you see is blast cell with hour rods. Okay, can you guys identify the hour rods and the blast cells with confidence?
Yeah.
Do you guys,
Yes.
you guys know what? Okay, good. Next one. Next one is okay, let me see. Okay. So the next one is if you have a patient with acute promyelocytic leukemia. Okay, what is the translocations of the genes?
17.
15, 17,
T15 and
17.
okay, T17. Okay, and what are the translocations?
Retinoid receptor.
Yeah, ABML with R with RAR A, RAR
Okay.
alpha.
APML to
RAR
okay, that's okay. So that's what's happening over here. So that's very good. Thank you, Dr. Hassam. I believe that was you. Okay, so good. And thank you to all the other physicians. I heard Dr. Adnan. I heard some other physician. I can't really recall the name, but thank you so much. Okay, next one. Okay, next one. Next one is if you have to have a patient with alcoholism. Okay, if you have a patient with alcoholism, what will happen is you will get folate deficiency. Okay, and this folate deficiency will result in a hypersegmental neutrophil. Hypersegmental neutrophil. And okay, so that's what's happening. This is just a statement. Okay, okay. If we do a GIMSA stain of a patient, if we do a GIMSA stain of a cell, and if an organelle appears blue, so what organelle appears blue under GIMSA stain? What organelle appears blue under GIMSA stain? What's your answer?
ribosomes.
NA.
Okay. Ribosomal RNA. Okay, good. Okay, next one. Next one is what is okay, next one. Next one is migratory arthalgia. Okay, next one is if you have a patient who comes to you with migratory arthalgia, the patient has renal damage and pancytopenia.
SLE.
Very good. This condition is known as SLE. Okay. Okay, next one. Next one is okay. So if you have a patient with paroxysmal nocturnal hemoglobinuria, this leads to hemosiderosis of kidney. Okay, so this is just a small statement. This is nothing important. Okay, next one. If you have a patient in which you do a biopsy, in the biopsy you see that the patient has a pleomorphic cells with binucleated with pigmented elements. Okay, this is extremely difficult. I do not expect you guys to answer this because this is very broad spectrum. If you see a patient with pleomorphic cells with binucleated with pigmented elements, okay, this is known as malignant. Okay, so this is what you expect to find in a patient with malignant melanoma. Okay, malignant melanoma. That's what it is. Okay, next one. Next one is so if you have a patient, once again, if you have a patient with AML and the patient has hour rods, okay, we talked about hour rods, and this patient has hour rods, okay, hour rods. Can you guys tell me which stain will the hour rod stain positive for? Hour rod stain positive for which stain?
Titrate something.
Myeloperoxidase.
Myeloperoxidase, yeah.
Okay, good. Good. Okay, next one. Next one is, what is the name of the syndrome in which can happen if there is a fast infusion of vancomycin?
Redman syndrome.
Redman syndrome.
Okay, Redman syndrome. Okay, next one. Next one is if you have okay, tumor cells. Okay, so tumor cells invade bone marrow by increased secretion of what? Does anyone have any idea?
Metalloproteinase.
Very good. The increased secretion of metalloproteinase. Okay, by increased secretion of metalloproteinase. Okay, next one. Next one. Okay, next one is okay. So before we do okay, that's not the question. Okay, okay. What is the name of this carcinoma in which you find uniform, small, round cells with scanty, clear cytoplasm?
Ewing sarcoma.
Very good. How do you know this? That is so surprisingly weird. Okay. Have you come across this question before?
Yeah, doctor.
Very good. Very good. Okay. Very,
In
very good.
hematology
Remember.
section.
Okay. Very, very good. So you are doing the questions really well. So thank you so much for doing that. You are helping yourself a lot and you're helping us. So thank you. Okay, next one. So uniform small round cells with scanty clear cytoplasm. I had a strong feeling that none of you guys would answer, but hopefully one of you guys did. So thank you so much. Even if I were in your case, I wouldn't be able to answer this. Okay, this is very broad spectrum. Okay, next one. Okay, next one. Next one is, what is the cellular lining of the ovary? What is the cellular lining?
Cuboidal.
Cuboidal cells. Okay, next one. Next one is, what are the substances that causes sepsis? I mean, by that, I mean the cytokines. What are the cytokines that are responsible for causing sepsis?
Tumor necrosis factor alpha.
Factor alpha.
Tumor necrosis factor alpha and
Interleukin 6.
Interleukin 6 and 1 maybe.
And
Interleukin 1.
very good.
1.
Thank you so much to all the doctors who participated. I believe it was, who was it? Dr. Adenom, I guess, right? Was it Dr. Adenom?
Yeah.
Okay, thank you so much, Dr. Adenom, and thank you to all the other doctors who participated. Okay, next one. Okay. Okay. Who else is participating today? So Dr. Adenom, we have Dr. Hussam, and we have another female physician. And who was that female physician? Who was the patient?
Siba.
Okay, good. Thank you so much, Doctor, for participating. Okay, just wanted to thank you for your volunteer. Okay, good. Okay, next one. Next one is, what do you find in a patient with okay. So the next one is, 1 second, please. Okay. Okay. So this is a description of colonic pathologies. Okay, description of different colonic pathologies. Number one is adenocarcinoma. Adenocarcinoma. Okay. So what do you find in a patient with adenocarcinoma? Okay. So if you do a histology, what you find is dysplastic cells with glands. Okay. Next one. Next one is CMV. If you do CMV, if you have a patient with cytomegalovirus infection of the colon, what you find is cytomegalo cells with inclusion bodies. Okay, next one. Next one is, if you have a patient who have if you have a patient who has cryptosporidium infection,
HIV.
What do you find? What do you find in a patient with cryptosporidium infection? Okay, so what you find is basophilic
inclusion body.
Very good. It's not the inclusion bodies over here. What happens is, over here you have basophilic clusters. So clusters of basophilic cells on intestinal mucosal surface. Okay. So next time when they want to describe you the conditions, if they say that there are dysplastic cells with glands, think about adenocarcinoma. If they talk about cytomegalo cells with inclusion bodies or big cells with inclusion bodies, think about cytomegalovirus. If they talk about clusters of basophil on the intestinal mucosal surface, it's cryptosporidium. Next one. Next one is Kaposi sarcoma. Okay. Kaposi sarcoma is basically spindle cells with vessel perfusion.
Infiltration. With infiltration, the cells.
That's correct. So spindle cells with vessel perfusion. Okay. Okay, next one. Next one is okay. Okay, next one. Next one is if you have a patient with syphilis. Okay, if you have a patient with syphilis and you do a histology, what do you expect to find in the histology of the patient?
Granuloma, goma body.
Okay,
Dark field.
so this is not the correct question. Okay, so I'm just going to skip out on this one. Okay, but the answer was correct, so that's what you expect to find. You can find gap or you can find gammas. That's not the problem. Okay, next one is okay. 1 second. Okay. So what metastasis is common? What types of metastasis is common with prostate carcinoma? What type of metastasis is common?
Bone
Bone.
metastasis first.
Okay. So there is a spinal cord metastasis. That's what we know. Does anyone have any idea which part of the spinal cord is more common for the metastasis?
Sacral or lumbar.
Not the division of the spinal cord. So we have the epidural part, intramedullary part. Does anyone have any idea which part is the prostate cancer most prone to get metastasized in? This is a very specific question, and this question is from MBOS. Okay, this question is from MBOS. Okay, does anyone know? Okay, so without wasting further time, okay, so the answer is it's commonly the metastasis is more in the epidural portion of the spinal cord. Common. Okay, 1 second. What metastasis is common with prostate carcinoma? And the answer is bone metastasis, and mostly in the spinal cord. And so spinal cord commonly. Answer is commonly in the epidural part of the bone. Okay, epidural part of the bone. Okay. Or what I want to write is exactly what is present in the epidural. 1 second. I apologize for the confusion. Epidural spinal metastasis. Okay. Next one. If you have a patient with lung cancer and that cancer spreads to the spinal cord, okay, which part of the spinal cord will get affected by the Mets? Anyone?
Of course, not epidural.
Okay, so intramedullary spinal metastasis. Okay, so it will be in the intramedullary spinal metastasis. Okay, so that's what it is. Okay. Next one is okay. So that's that. Now, okay. So do you guys want to leave it up to here? Do you guys want to leave the UWorld notes up to here for today?
Okay.
Yes. Okay, let's do our random 5 questions. Okay, perfect. So today what we'll be doing is we'll be doing 1, 2, 3, 4, 5, 6 questions from pathology. From okay, that's what we're going to do. 1 second. Okay. Okay, 1 second, please. Okay. Okay. Feel free to help with the feelings of us. Okay, so this is what we're going to do. Questions. Going back to the chat box and seeing who answered what. Okay. This question, and when I ask you the answers, only then please answer. Okay, so that it gives everyone a chance to understand. Okay. Okay. So first of all, let's read the question. So how should you address a question from okay, so we will read the last the patient should be questioned about which of the following diseases. Okay, so if you want to make of yes, which should be a question and concern. Okay, patient has severe arthritis involving the lower back. Okay, so patient has arthritis. So which one of them do you think is the answer for this question? Anyone? Anyone? Which one of this is the answer? Let's see who has a. Anyone? Does anyone have any idea? Anyone?
Celiac disease.
Doctor C, Crohn's disease.
Okay, who else? Who else? Anyone else? Okay. To the doctor who mentioned Crohn's disease, why did you mention Crohn's disease? Why do you think C is the answer?
Maybe it's associated with HLA-B27 also.
Okay, so what's happening? Okay, so what's happening is
I would go with B. B maybe.
B. Okay, B. So we
Celiac
have
disease.
B. Without further ado, the correct answer is C. Okay, the correct
C.
answer is C, Crohn's disease. And the reason why Crohn's disease is the correct answer is because people who have been diagnosed with Crohn's disease, okay, these people, what they have is these people, they also have joint pains that resembles ankylosing spondylitis. Okay, so Crohn's disease patients have joint pains which resembles ankylosing spondylitis. So before you want to make a diagnosis of ankylosing spondylitis, you always want to check if the patient has Crohn's disease or a previous history of diagnosed Crohn's disease or not, because the arthropathy associated with Crohn's disease is almost the same as the arthropathy associated with ankylosing spondylitis. Okay. Okay. Next question. Okay. Next question. Okay. So did everyone understand that question? Did everyone understand? Okay. Good. Okay. Next one. Which of the following abnormal laboratory values might be expected in this individual? Which of the following abnormal laboratory values might be expected in this individual? Okay, next one. Next one is, so you have decreased alpha-2, decreased fibrinogen, increased calcium levels, low albumin, and red blood cell counts in the urine. Okay. Which one of this is associated with which one of this is abnormal in these individuals? Okay, so let's read the first line. A 3-year-old child develops general edema following a viral infection. Okay, okay. So which one of this is important to underline? If someone had to underline this, can I get some active participations, please? Which one of this is important to underline?
Age of the child, 3 years old.
Generalized edema.
Generalized edema.
Edema and viral infection.
Okay, so basically this line is altogether very important. Next one, on the basis of clinical chemistry, a renal biopsy is performed, which demonstrates normal light microscopic finding. Is this line important?
Yes, they're important.
Okay, so this is important. Okay, just write down normal light microscopic finding. Now the question is, which of the following abnormal laboratory values might be expected in this patient? What is your answer?
D. Low serum albumin levels.
Does agree with D?
Yes.
Does anyone have any other suggestions? Okay. What is the diagnosis of this patient, please?
Nephrotic
Minimal
syndrome.
change disease.
Very good. Minimal change disease, nephrotic disease, and the answer is D. Very easy. Next one. Okay. Okay. Next one is, this finding is most consistent with pathology of which of the following arteries? So they're talking about an artery. A patient with long-standing hypertension dies in a cardiac accident. At autopsy, multiple small cavitary lesions are observed in the basal ganglia. Okay, the basal ganglial arteries. And what is the artery that supplies the basal ganglia? I wanted to talk about this artery today. Okay, but I thought I would be talking about this artery later. But fortunately, we got a question about this, so we'll be talking about this artery anyways. Which one of this do you think is the right answer?
I think B, doctor. Lateral striate.
Well, we have students who have said B. Does anyone have any other suggestions? Okay, no other suggestions. So B is the correct answer. It's lateral striate or lenticular striate arteries. These are the branches. These are the branches of the middle cerebral artery. Okay.
Doctor, it is the same with lenticular striate also?
Yeah, right. Striate arteries. Lenticular striate or lateral striate. That's the same thing. Okay. Okay. Next one. Next one is, the finding is most useful for diagnosis of which of the following disorders. Okay. The finding is most useful for diagnosis of which of the following disorders, and what are the answer options? Alpha thalassemia minor, beta thalassemia major, hereditary spherocytosis, sickle cell anemia, sickle cell failure. Okay, what is the problem? The clinical path lab at the hospital receives a specimen from the pediatrics unit. Laboratory study shows a marked susceptibility of the red lysis in hypotonic solution. Easy
Hereditary
question.
spherocytosis.
Yeah,
C,
easy.
yeah.
C.
The answer, please.
C.
C.
Okay, the answer is C, and this is very easy, so I'm not even going to discuss. Okay, next one. Okay, next one. Next one is, which of the following is the most likely cause of this arrhythmia? Etiology of this arrhythmia. Okay. So we have atrial reentry, automatic atrial conduction, AV dissociation, AV nodal reentry, and wandering atrial pacemaker. Okay. This should be a bit difficult, but still, I'm sure some of you will be able to answer. A 75-year-old man with angina has recurrent episodes of tachycardia. A rapid sequence of normal QRS wave is seen on EKG. The episodes are controllable by the patient's performance on vagal maneuvers. Which of the following is the most likely etiology of this anemia, of this arrhythmia? I'm sorry. What is the answer?
Possibly A, atrial entry.
We have one. We have one student who said A. Does anyone else have an idea?
I think
D.
Anyone else?
I think D also. D.
Okay, so one who said A, another one who has said D. Why do you think the answer is D?
Because they mentioned that by vagal maneuver, it could like control.
Okay, and which
I
one?
think this is
Because
supraventricular
vagus can suppress the
tachycardia.
AV.
No, which one of these are controllable by vagal maneuver?
D.
Atrial
Because AV node is controlled by vagus.
There we go. Okay, so the answer is actually D. Okay, the answer is actually D. Who was the doctor who said atrial reentry?
Me.
Okay, so
This
why did you
I think this case is a case of supraventricular tachycardia, which can be supraventricular tachycardia, which is above the AV node in the atrial compartment, just like the WPW. These cases, they are controlled by vagal manipulation.
Right. But what's happening is, my question was, which of the nodes can you control with vagal maneuver? Which node is, so for the thing is, the most important line for this question is this one over here. The episodes are controlled by vagal maneuvers. The episodes are controlled by vagal maneuvers. So first of all, does anyone know what a vagal maneuver is?
Yeah.
Yes.
Okay, what is a vagal maneuver? We have talked about this.
It could be
massage to carotid
carotid massage or orbital massage.
Or eye massage.
Right.
Massage
or carrot massage. And what we do is, when we try to massage that place, we try to decrease the conduction from the AV node to the rest of the signaling pathway, right? So if a patient has arrhythmia and we try to do a carotid massage, so basically if we do a vagal maneuver, the node that will stop or decrease its impulse transmission is the AV node. Okay, so the answer is D. Okay, so is that clear, Dr. Adano? Dr. Adano,
I think, yeah, because the first sentence, this is a patient with angina pectoris that has recurrent episodes of atrial tachycardia. And
Yes.
atrial tachycardia.
Oh, that's why you thought.
Afterwards, you see
atrial tachycardia, it is controlled by the SA node, not the AV node.
Complete the sentence.
No.
The next one.
I understand your confusion. Okay, so your confusion is, you are telling that the answer could have been atrial reentry. Okay, the answer could have been atrial reentry because the tachycardia is an atrial tachycardia, and you are saying that the SA node the SA node is important for the transmission of. Okay, but what's happening over here is, even if there is atrial tachycardia, can you control atrial nodal stimulation by vagal maneuver? Dr. Adhanom, is it yes or no?
Yeah, I don't know.
Okay,
I'm going to check it. Yeah,
difficult to control your SA nodal. Okay, so the thing is the pacemaker of the heart, right? So it's impossible to control the nodal. Okay, so let me draw this one for you. Okay, I know this can cause a lot of confusion. This question is actually not that difficult. Okay, so let's say you have SA node, right? And from SA node you have AV node, right? Okay, AV node. But SA node over here is the pacemaker of the heart. The SA node makes or creates the impulses, and then the SA node, it causes transmission of the impulses to the AV node, and then from the AV node it goes to the rest of the conduction system. But if you have to do vagal maneuvers, let's say even if you have to control the impulse transmission from the SA node, if you block or cut off the AV node or decrease the AV nodal activity by the vagal maneuver, can the impulse travel from the SA node to the rest of the conduction system? Yes or no? Yes or no?
It will decrease.
It will decrease. Yes, that is correct. So it will obviously decrease. And at the same time, if this decreases, does it also decrease the activity of the SA node? Yes or no?
Possibly.
Yes or no?
Yeah, maybe. I don't know.
It does. Okay, so if you decrease the activity of the AV node, the SA node cannot transmit the impulses from the SA node to the AV node. And at the same time, even if this does not make enough sense, they have mentioned very strictly that they have done a vagal maneuver. Okay, they have done a vagal maneuver. If they have done a vagal maneuver, there's only one type of arrhythmia which you can control with vagal maneuver. That's an AV nodal reentry tachycardia. Okay, so AV nodal arrhythmia. Okay, so with that being said, and as a matter of fact, the fact that Dr. Adenom mentioned atrial reentry, okay, atrial reentry, the answer percentage for atrial reentry is 55%. Okay, and the answer for AV node is 22%. Okay, so this is a very difficult question. Okay, this is a very difficult question, and the confusing part was the main part which Dr. Adenom mentioned, that the atrial tachycardia and SA node. But at the same time, when something like this happens, if you can try to just keep in mind that the last question was asked that they have successfully controlled the performance by doing vagal maneuvers. The vagal maneuvers are the one which could be done with only AV nodes. Okay. So should we move forward? Are we good with this?
Yeah.
Okay. Okay. I'm sure most of you are super tired. You're like, yes, we're done. Okay, go. Okay. So, okay. So we're just gonna go forward. Okay. If you guys have any confusion about this one, please let me know. Okay. Next one is, which of the following disease is most consistent with this laboratory result? So we have a laboratory result. I think this is the one. Okay. Okay. And bronchiolitis, cellulitis, diphtheria, epiglottitis, pertussis. Okay, a 2-year-old girl has an infection. A complete blood count reveals increased number of white blood cells shown above. Okay. Okay. So this is the one. Okay. So increased number of white blood cells shown above. Okay. This is a very clear-cut picture of one white blood cell over here. The rest of them are mostly RBCs. What is this white blood cell? RBC, lymphocytes or?
Lymphocyte.
Lymphocyte.
Okay, which of this can have lymphocytes?
The viral, of course.
Bronchiolitis.
Okay, so what is the answer?
Just a minute.
The answer is A. Perfect. So this is an easy question. Okay. Okay. So are we good? Are we done?
Yes.
Okay, we are done for.
Yes.
Thank you so much to all doctors who participated. You guys liked the lecture today? Did we have problems? Okay, so what I decided is since we don't get much feedback in our page, I'm going to ask you guys if the lecture was okay, or how do you think we can change the lecture so that it could be easy for you. So I am open to feedbacks right now. I am open to learn if there's anything we need to change about the lectures so that you can get better suited. So is there anything I should know about, or any feedbacks that I should know, anything that we should do to change the
oh, sorry, doctor, to interrupt you. Is it maybe possible also after, if you do UWorld question, that we could maybe do one to the topic which we, like, for example, discussed today?
Right. Okay. So so we had a question from Dr. Karbasi, and he is asking whether we can do associated UWorld questions with the topics that we have discussed today. Is that your question? Yes or no? Yes or no? Is that your question?
Yes.
Okay, yes, okay. So the thing we can do UWorld questions associated with the topic, and as a matter of fact, that's exactly what we were doing for the last couple of days, until and unless recently what we started doing was we started doing Kaplan questions. Okay, but before this we were doing UWorld offline questions associated with the topic. So what we can do is what I thought that instead of doing specific system-wise questions after the end of the lecture, since we are doing systems as of right now, if we do some random questions about the topics that were discussed previously, This will help us do a quick revision from here and there about the topics we have discussed before. But if everyone is okay with doing questions from the specific systems, then we are also okay with that. That's not a problem. We even have UWorld offline questions. So let's say tomorrow, what we can do is after the lecture, we can do associated neurology UWorld offline questions. So is that okay? How about everyone? Okay, good. So we will do offline UWorld neurology questions as per the suggestion of Dr. Karbasi, and also for the as per the suggestions of everyone else who have agreed. Okay, next one. Any more questions?
Oh, doesn't mean we won't do random anymore.
I'm sorry. Who? What the question again, please?
I'm like, doesn't mean go ahead with random questions anymore because I feel it's also okay to do.
I apologize, Dr. Ude. I'm having a difficult time hearing your voice. Is it possible for you to write it down?
Okay.
Okay. Okay, so we have a question coming from Dr. Ude. In the meantime, does anyone have any other question? Okay, the lecture is over, guys. So if anyone wants to leave, they can leave until and unless they have a question, they can stay back and ask. If we have no further questions, then after answering Dr. Ude's question, I would like to leave. Okay, can we still do random? Because I feel like it's still okay to. Okay, so what? Okay, so this is what we can do. So today we are going to do specific system-wise questions. The next day we will do random. Okay. Does that sound good to everyone? Okay. Okay, good. So now, okay, good. So we would, that's what we would be doing. So on one day we will be doing specific questions, and the other day we will be doing random questions from Kaplan. Okay. Okay. Anyone else with any other questions, concerns regarding preparations, regarding anything, regarding transactions, regarding our lectures, regarding our future plans or anything? Does anyone have any questions they want to ask regarding USMLEs? Okay, good. So no one has any questions. So if no one has any question, that means every one of you are happy with our lectures. So thank you so much for supporting us. Thank you so much for putting your time and trust lectures. Okay. And please let us know if there's any way we can improve ourselves. Okay. And if you like our lectures, please let your friends and colleagues know, because the reason why is because USMLE is the tutors who tutor USMLE Step 1, they charge an immense amount of money for a small amount of time, which they go at the same time. I'm not trying to go against anyone, but the tutors over here, they charge around $40 minimum per hour. Okay, so if you were being tutored by someone else, 25 hours a week would come to close to around $2,000 a week. Okay, so but we only charge around $25. That's around $1 per hour. Okay, so if you like there's anyone else in need who needs help with USMLE Step 1, please ask them to come and join us. We do provide 1 day of free lecture, as you guys have started out that way. Okay, so you guys can let your friends and family know, your friends and colleagues know, if they need help, they can come and join us. And what also we would really appreciate is if you guys could give us some feedback and ratings on our page to let us know if we are doing a good job or not. All you have to do is just go to our page, that is Dr. Haidari on Facebook, and on the rating section, just please let us know if we are doing a good job. If we are, just give us a good rating. If we are not, then please give us a rating that is most suitable, and let us know how we can improve ourselves. Okay. And another question is, could you maybe send me UWorld offline questions? So the thing with our UWorld offline questions are books. Okay, so we have books, so it's absolutely impossible to send you the questions. What we do is we take pictures from the book, and so what we do is we also use the UWorld offline question for self-assessment exams. Okay, so we also use the UWorld offline questions for your self-assessment exam. So I apologize. I'm really sorry, but I feel like if there are like close to around 3,000 pages, okay, so it's impossible for us to send 3,000 pages of questions. But hopefully you guys can find the PDFs of the offline questions online. Okay, so that's what it is. Okay, so with that being said, we have only 12 students left. Okay, I don't know what you guys are waiting for. So hope you guys are waiting for me to leave. So I am going to leave. Okay, so thank you so much once again for staying this long. Okay, good. Now we have 10 students. Okay, good job. Okay, all right. So hope you guys have a good day, and hope to see you guys tomorrow again at 9 a.m. Let me know if there's anything else you need and send me an email. Thank you.